ಅಲ್ಲೊಂದು ಯೂಟ್ಯೂಬ್ ಕ್ರಿಯೇಟ್ ಆಗಬೇಕು. ಆಡಿಯೋ, ಸ್ಟೀರಿಯೋ, ವಿಡಿಯೋ, ಬೈಕ್ ಇದೇನು ಮಾಡಲ್ಲ. ಹಾಟ್ ಕೀಸ್ ಆಕ್ಸೆಸ್
Good morning, everyone. And as I want to echo JP's welcome to our first annual GPED meeting, and I hope that everyone will enjoy all of the things that we have to offer. I have the honor of opening our first plenary session today. My name is Dr. Diane Stafford, and I'm one of the vice presidents of GPED, and I'm a pediatric endocrinologist from Stanford University in California. And I am very pleased to introduce Dr. Ana Aceves Capri, who is a physician from Mexico who works for the World Health Organization, providing technical advice on projects related to the WHO model list of essentials in vitro diagnostics. And she will be speaking today on the role of bringing these essential diagnostic tests to resource from Mexico, who works for the World Health Organization, providing technical advice on projects related to the WHO model list of essentials in vitro diagnostics. And she will be speaking today on the role of bringing...
Before starting with my presentation and while I'll share the screen,
This meeting is being recorded. This meeting is being recorded.
Care for children with endocrine disorder globally. Now, as we move into day 3, let's take a moment to reflect on the previous session of our meeting and highlight some key insights. On day 1, we launched the conference with a powerful opening that set the tone for our shared journey. we explore some of the pressing challenges in pediatric endocrinology with a particular emphasis on the need constraint setting, diagnostic test, resources constraint setting. This early menarche and the other on medicine to manage weight in adolescent. Following this, we delve into the first symposium of the meeting, the Adrenal Symposium, which led a discussion on adrenal disorder, focusing on diagnosis and management strategies that are both innovative and practical for diverse healthcare setting. The day closed with an engaging plenary on the phenotype of type 1 diabetes in sub-Saharan Africa. Day 2 was equally impactful, beginning with the plenary on e-learning. We then shifted our focus to newborn screening, one screening program in low resources area, underscoring the importance of early detection for conditions like congenital hypothyroidism. This followed by Meet the Expert as a tool for the SD assessment. Equally, the role of the early versus late genitoplasty. The last plenary on the first weekend focused on the influence of puberty, nutrition, and endocrine disruptor on peak bone mass. Throughout the day, we were inspired by the dedication of our colleagues working in the challenging environment and their unwavering commitment to providing quality care to the. We thrilled to build on this discussion with an exciting lineup of speaker and session that promise to deepen our understanding and strengthen our professional connection. Our agenda today includes a plenary on the assessment and treatment of vitamin D deficiency or nutritional recap, a diabetes symposium, to meet the expert, one on the SGA and the other on the much awaited oral presentation. Ending in the day is a plenary on the teeth as a marker for endocrine disorder. This exchange of perspective will be invaluable as we native such complex decision in our practice. One thing that is poster that were submitted to the first GPED annual meeting. We received 46 abstract submission from 19 countries. There are 33 poster presentation available for you to view both days, and there are 6 oral presentation today as well. Please scroll to the showcase option on the virtual event platform. Yeah. And before we begin, I'd like to take a moment to thank each of you for your active participation and enthusiasm. Your engagement has truly enriched this experience for everyone involved. We would like to encourage you to actively participate. Please exit full screen box on the feedback form at the end of today's session. Your input is invaluable in helping us improve future events and better serve our community needs. Keep yourself via platform, which will share via the chat throughout the meeting. We also encourage you to register to become a GPED member for free via our website. Link will be shared via the VidLoop chat as well. So let's keep the energy high and make today just an engaging and productive as the previous day. The first session on the day will begin at 1:15 p.m. GMT. Thank you for being here, and let's dive right in. Thank you.
This meeting is being recorded. This meeting is being recorded. This meeting is being recorded.
welcome meeting. We are going to start the plenary, and this is a very important session. In the past few decades, the knowledge regarding vitamin D has generated a huge number of publications, a lot of curiosity about role of vitamin D beyond bone and muscle health, and it has equally generated those many controversies about what is the ideal level, what sort of a dose should be given to replace or prevent vitamin D deficiency. And to speak on all this, we have today with us Professor Anju Seth. I'm very pleased to introduce her for this plenary. Can we have her introductory slide, please? Professor Anju Seth is Director, Professor, and Head of the Department of Lady Hardinge Medical College, a very well-renowned medical college in New Delhi, India. She wears many hats. She's an excellent pediatric postgraduate teacher. She is a pediatric endocrinologist. Her work in vitamin D and calcium and several other conditions is very well known. She also is an expert in pediatric HIV. She has several number of publications to her credit. She has been our past president of Indian Society for Pediatric and Adolescent Endocrinology, and she has also been in several other positions. So over to you, Professor Anju Seth, to cover this complex topic in the next subsequent 30 minutes. This is a plenary session, so we won't be having Q&A session, but I think if we get any queries in the chat box, then we can pass it on to you for you to answer.
Thank
in
you,
the chat.
Ganesh. May I share my slides? Slides visible?
Yes, Dr. Anju Seth, they are visible.
Thank you. And a very good day to all the participants today. So I would like to thank Professor Shenoy and Dr. Ganesh for inviting me to speak on the forum of GPED. And as he said, I'm going to speak on assessment and treatment of vitamin D deficiency. And I propose to cover briefly assessment of an individual's vitamin D status, the manifestations of vitamin D deficiency, management of symptomatic vitamin D deficiency, and finally, I'll dwell a little upon the dilemma of asymptomatic vitamin D deficiency. So to begin with, how do we assess vitamin D status of an individual? Now, there are several metabolites of vitamin D circulating in the plasma. Among them, the most abundant is 25-hydroxy-vitamin D. It also has a rather relatively long half-life of 2 to 3 weeks. Therefore, a steady-state plasma concentration is there. And total serum 25-hydroxy-vitamin D, therefore, best indicates the vitamin D status of an individual. The active form of vitamin D, that's the 1,25-dihydroxy-vitamin D, is then formed by renal or extra-renal 1-alpha hydroxylation. And 1,25-dihydroxy-vitamin D is, of course, its formation is controlled very, very tightly by hormonal control of PTH, FGF23, serum calcium level, among others. And that's present in a very small amount as compared to 25-OHD. So what constitutes vitamin D deficiency? So one way of looking at it is the level of serum 25-OHD below which the PTH levels start rising, thereby indicating a state of increased bone turnover. So if you look at this figure, this is from a publication by Atakadu et al. 2013, what we see is that 25-OHD levels below 34 nanomole per liter, that translates to 13.6 nanogram per ml, the PTH levels start rising. So, and several other workers also have found that PTH levels start rising somewhere around a 25-OHD level when it falls below 13 to 14 nanogram per ml. And several works have also shown that nutritional rickets and other symptoms of vitamin D deficiency become increasingly common as 25 OSD levels dip below 12 nanogram per ml. So it's reasonable to keep a target of say 20 nanogram per ml. This would avoid prolonged periods in any individual of levels below 12 nanogram per ml. As we know, there are several factors that can affect 25 OSD levels, most important being seasonal variations. During winters, the levels are known to dip. So a target of 20 seems a good target to keep. So there are several organizations that have attempted to define vitamin D deficiency. And as you can see in this table, there is not 100% agreement among them regarding what constitutes sufficiency and what constitutes insufficiency. So, and there are reasons for those. Primarily because we do lack robust evidence that correlates 25 OSD level with the health outcomes. Likewise, no clear threshold of 25 OSD has really been found that optimizes the calcium absorption. And further, the relation between PTH and 25 OSD, also the one I referred to in the last slide, gets influenced by other factors like age, gender, etc. So there is some difference, but by and large, the last global consensus guidelines that were published in year 2016, and I was privileged to be part of that group that formulated those guidelines, define vitamin D deficiency if the 25 OSD levels were less than 12 nanogram per ml, and sufficiency if the levels were more than 20 nanogram per ml, and the intermediate range indicating a state of insufficiency. Then the Indian Academy of Pediatrics, in its own guidelines that were published later, endorsed the same levels. So all of us are well aware of the skeletal consequences of vitamin D deficiency. And over last few decades, a host of extraskeletal consequences have been ascribed to vitamin D deficiency. And of course, now we do increasingly face the situation where in an apparently healthy individual, asymptomatic deficiency is picked up because of the so-called routine assessment of 25 OSD levels. We'll speak about this a little later. So indeed, what now seems to be evident is what is manifest is a very, very minuscule proportion of all the individuals who may be considered to have vitamin D deficiency if we are to check their 25 OSD levels. So skeletal manifestations like this are familiar to every pediatrician and pediatric endocrinologist, and these tend to be most florid in the second half of infancy and the first few years of life. When we talk about infants under 6 months of age, it's important to realize that the skeletal manifestations may not be so obvious. So they are seldom a presenting complaint in infants under 6 months of age. Indeed, very often these children present to us with another illness like mostly a lower respiratory tract infection, and that is the time that subtle manifestation may be picked up by a clinician. So what I've presented here is the data from my own students' publication, and where we actually found, and there are several other publications including more from our own group also, where we found that in young infants, hypocalcemic seizures are the commonest manifestation of vitamin D deficiency. And it's also well worth keeping in mind that apart from these, the hypocalcemic seizures and subtle skeletal malformations, these children can also present with stridor and dilated cardiomyopathy. And one should remember vitamin D deficiency as an etiology here because these are so eminently treatable. Just by treating the deficiency, one can treat these disorders. When we come to adolescents, again, the typical skeletal manifestations become less obvious. And these adolescents tend to present with more non-specific complaints like a lower limb pain. They may present with difficulty in walking or climbing stairs as a manifestation of proximal myopathy. Indeed, this on the right side of this slide, I've showed this study by an orthopedic surgeon where the group has shown that more than 25% of adolescents who presented with non-traumatic joint and limb symptoms actually had nutritional rickets. And another manifestation that becomes again obvious in adolescence is this, what I've demonstrated here, the tetany or again hypocalcemic convulsions. And we have several times come across a situation where epilepsy is diagnosed in patients with hypocalcemic seizures, and these children are given anti-epileptic drugs without realizing the cause is actually hypocalcemia secondary to vitamin D. So moving from the skeletal to extraskeletal roles of vitamin D, and over time, as a host of roles have been ascribed to vitamin D. Many human cells have been shown to carry the vitamin D receptor, as indeed the enzyme 1-alpha hydroxylase. And what is realized is that vitamin D has anti-inflammatory, antioxidative, and immunomodulatory effects. So a whole lot of disorders are kind of linked to vitamin D deficiency, be it psychiatric disorders, pulmonary, cardiovascular, immune, and so on. However, the evidence linking these disorders, these various adverse health outcomes with 25-hydroxyvitamin D levels are mostly observational studies. And so a possible role of 25 vitamin D deficiency has been indicated in pathogenesis of infectious and autoimmune diseases. However, RCT of vitamin D supplementation in these conditions has not given very convincing results. Therefore, as of today, there is insufficient evidence to support vitamin D supplementation for anything other than skeletal health benefits in infants and children. And guidelines for treatment of vitamin D deficiency are also based on its skeletal consequences only. We monitor the skeletal outcomes also when we treat the vitamin D deficiency. A little bit more about the symptomatic vitamin D deficiency. So, of course, we are well aware that nutritional rickets is the commonest manifestation of vitamin D deficiency, and it is also the commonest cause of rickets. Thus, a standard pediatric teaching has been that all cases of rickets presenting at a pediatric setup may well be presumed to be nutritional rickets unless there are pointers for non-nutritional etiology, and I'll speak about them a little later. Of course, the situation may be a little different when we are talking about a pediatric endocrine setup where we expect more of non-nutritional rickets to be finally reaching. Speaking a bit about nutritional rickets, we should realize that all nutritional rickets is not pure vitamin D deficiency. Rather, nutritional rickets presents a spectrum where at one end we have pure vitamin D deficiency as its etiology, and on the other, pure calcium deficiency. While most of the cases of nutritional rickets actually have somewhere a mix of both. So this work that we had published about 12 years back was a case control study where we just compared children with rickets with age-matched healthy controls. And what we found was that 25 OHD levels in these two groups were not significantly different. They were lower in children with rickets, but in both the groups, they were in the insufficiency range. However, what was different was the calcium intake, which was significantly lower in children with rickets as compared to the healthy controls, as also the proportion of calcium coming from dairy sources, which has a lot more bioavailability as compared to the non-dairy sources. So we had concluded at that time that low 25-hydroxyvitamin D causes rickets only in presence of low calcium intake. The same concept has been presented very beautifully in this cartoon, which is from the Global Consensus Guidelines I referred to earlier, which just shows that the osteoid mineralization, there are the two main determinants are the vitamin D status and the calcium intake. If both of them are normal, vitamin D status and calcium intake, or even if one of them is insufficient and other is normal, the balance is positive and osteoid mineralization is fine. If one of them is normal and other is deficient, or both are insufficient, it is somewhat precariously balanced, and any stressor can tilt the balance in favor of rickets, and sometimes there might even be early biochemical abnormalities. At the third extreme, if both are deficient or one is insufficient and the other is deficient. In other words, deficiency of one cannot be compensated by sufficiency of the other, frank rickets occurs. This recent publication, which was actually a meta-analysis of 120 studies with more than 5,000 participants, actually showed that minimal risk threshold for development of rickets was 28 nanomoles per liter of serum 25-OHD if children had adequate calcium intake. However, if the children had a dietary calcium deficiency, the same threshold was elevated to 40 nanomoles per liter. So based on the discussion that we have gone through, the principles of treatment of nutritional rickets are like this. One, we must always give both vitamin D and calcium. The minimum recommended dose of vitamin D is about 2000 international units per day. Oral calcium in the dose range of 50 to 75 milligram per kg per day, either as a dietary intake or as a supplement, should be given along with. The minimum treatment duration is recommended for 12 weeks, recognizing that some children may require it longer. And this should be followed by maintenance therapy. And finally, one should use vitamin D, either D2 or D3, but we should not really be using calcidiol or calcitriol for treating nutritional rickets. Not only do these compounds have a short half-life, they are more expensive, they have more toxicity potential. Moreover, they do not get stored in the body. So please use ergocalciferol or cholecalciferol. So again, this slide is showing the recommendations regarding dose of vitamin D for treatment of nutritional rickets. And again, some little differences in the regimes which have been recommended. So let's focus on the global consensus guidelines. So as per the global consensus guidelines, the minimum dose, as I said, is 2000 IU per day for 12 weeks, and that is what we give in infants. For children beyond 12 months till 2 years, the dose recommended is 3000 to 6000 IU per day, again for 12 weeks, and for children beyond 12 years, the dose is 6000 IU per day for 12 weeks. The maintenance dose is 400 IU per day for infants, and beyond that 600 IU. The Indian Academy of Pediatrics guidelines Indian Academy of Pediatrics guidelines also have endorsed the similar daily dose of 2000 IU per day for infants, but beyond that, we have recommended using 3000 IU per day for all children beyond infancy. But we have also recommended using an alternative dosage regime of using an intermittent regime, which I'll be speaking about a little later. But before that, when do you suspect non-nutritional rickets? There are some very clear pointers to non-nutritional etiology. So these would include the, say, presence of a chronic liver and kidney disease, which would affect the 25 hydroxylation and 125 hydroxylation. Presence of, in the setting of consanguinity, presence of familial occurrence would indicate presence of inherited disorders. Cataract and intellectual disability pointed towards Lewis syndrome. Acidosis, hypokalemia, failure to thrive, we are thinking of possible RTA, nephrocalcinosis, alopecia, of course, PDDR type 2. And very important, if there is no response to an adequate treatment for nutritional rickets. And that is something we must always inquire when you get a child with rickets. Because sometimes a child with non-nutritional rickets does not get a response. Therefore, they do tend to visit different clinicians. So it's very important. And whenever we face such a child with rickets, we must inquire into previous administrations of calcium and vitamin D to avoid inadvertent vitamin D toxicity, which we come across quite often in such cases. So just coming to some practical aspects of vitamin D therapy, what works? Do we need parenteral therapy, or is oral good enough? So there is enough evidence that both oral and parenteral therapy are equally effective in restoring biochemical as well as radiological healing in children with rickets. In fact, there is some evidence, you can see here, that oral treatment restores 25 OHD levels more rapidly than the intramuscular treatment. Thus, there is a consensus that really there is no need for injectable vitamin D, maybe except in some malabsorption states. So oral works well. So why give injectables? So something that we used to do earlier, we in India at least, injectable vitamin D used to be given as a single shot therapy. It's no more being done. And I think for the last maybe about a couple of decades, we have stopped doing that. Just sharing with you that this work by one of my students, where we showed that oral vitamin D works well for celiac disease as well. So what we did in this work was that in newly diagnosed cases with celiac disease who had vitamin D deficiency or insufficiency, we gave them oral vitamin D at 60,000 international unit per week. It comes to about 8,500 international units along with calcium for 12 weeks, and we initiated them a gluten-free diet. What we found was a very robust rise in 25 OHD levels. In 12 weeks, the median levels went up from 12.5 to 64.9 nanogram per ml, thereby indicating that the oral works well in at least celiac disease. Of course, once we give a gluten-free diet, there can be a rapid mucosal healing. So, at least in celiac disease, there is no need to give injectable vitamin D. We cannot extrapolate these results to all malabsorption states, but it is well worth trying in those states as well. So, just another question which we often think about: what works better, D2 or D3? So, the evidence indicates that it doesn't matter what we give; both of them work well. Especially when we're giving daily therapy, there is no difference that is noted between D2 and D3 therapy. As far as bolus therapy is concerned, there is this publication, and this is a meta-analysis of 10 studies which concluded that bolus D3 is more efficacious in increasing serum 25 OHD levels as compared to vitamin D2. The likely cause could be maybe, that D3 may be a preferred substrate for 25 hydroxylase in the liver. But really, both D2 and D3 work. So we should use any of them, whatever is available to us, whatever we are comfortable using, both will work. A word about the STOS therapy, which again has been used till at least a couple of decades back in India. A bolus dose of 600,000 IU was actually being used quite often, both as oral formulation as well as injectable formulation. However, over the last couple of decades, as more and more evidence has come in that these kind of mega doses are not only not needed, they may actually be harmful. So various authors, including my studies by my own group, have shown that these children may have hypercalcemia and hypercalciuria, and several children may develop serum 25 OHD beyond 100 nanogram per ml. So in the current times, when the lower doses are found to be effective and safer, there is really no role of using the single large dose of STOS therapy current times. Now, a few words about the intermittent vitamin D therapy that I spoke about in the couple of slides back. So in India, we get a formulation of vitamin D, which is 60,000 international unit in a sachet form, which gives vitamin D as a form of granules. Now, these are very palatable, can easily be mixed with milk, or even just, a child they can just be put in a child's mouth and the child can drink water or milk followed by that. Good bioavailability, good palatability, and very, very economical. So, these sachets have been used in our country very, very often. So, in these works, we try to see how these sachets work. So this particular work, which was published this year only, we gave daily 4,000 IU of vitamin D versus equivalent dose fortnightly. So this was 60,000 IU every fortnight for 3 months. And in the treatment of symptomatic vitamin D deficiency in children aged 1 to 10. And what we found was, as you see here, both the regimes, this is the daily regime, this is the bolus regime, they worked well. The levels, every child had a robust rise irrespective of the regime. Another work which was published last year, we did similar work in infants where we gave 2,000 IU per day as per the recommendation versus equivalent dose of 60,000 IU given every month. Again, we gave for 3 months and similar findings, a very robust rise in vitamin D levels in both the groups. We also found that both groups had very robust rise in serum calcium and phosphate levels, fall in ALP and PTH, complete radiological healing of rickets, and you must have noticed in the previous slides, since both the daily and intermittent regime work well. However, the rise in 25 OST levels in daily regime was actually more than in intermittent regime. It assumed statistical significance only in the study on infants, though. Another observation that we had was that both the groups, daily as well as intermittent, had some children who had transient hypercalcemia and or hypercalciuria. And thus emphasizing that whenever we treat these children, we should be periodically monitoring these children. Moving from the symptomatic to asymptomatic vitamin D deficiency, and that's a dilemma we face increasingly these days when patients come to us with a report and vitamin D levels has been done for maybe just a routine screening or maybe for some non-specific symptoms. So what do you do if there is incidentally detected vitamin D deficiency? Well, if it's an infant we come across, I suppose it's logical to treat it because these infants, there is enough evidence to say that symptomatic vitamin D deficiency is very common in infancy. They are so vulnerable, they are growing fast. And in any case, there are guidelines that all infants should be supplemented. So I suppose if we come across deficiency in infants, even though they might be asymptomatic, we would perhaps like to treat it, and treatment should be followed by preventive supplementation. Can we say the same for older children? Now here we are treading on slightly gray zones. Ideally, this situation should not arise because really there is no indication for checking 25 OSD levels in healthy children. And the other factors also, if it has been checked, they were healthy, there were no symptoms. So how do we assess the benefits of treatment? Another problem is if we have done it for non-specific symptoms, say bony pains, we might actually miss another serious diagnosis if low vitamin D level is ascribed the causality for these non-specific complaints. And I do remember at least one child where leukemia was missed in bone pains. And while we were, well, not we thankfully, the treating physician was actually treating the child for vitamin D deficiency. And again, there is no evidence, no studies to guide the dose or the regime in asymptomatic individuals. We do not know what level to target. Thus, if we do come across this situation where the levels are say less than 10 nanogram per ml or 12 nanogram per ml in a healthy child, one can perhaps review on a case-to-case basis, and one may consider treating with simultaneous correction of risk factors, and that's important, ensuring an adequate calcium intake and sun exposure, keeping in mind that there is a high chance that deficient state will recur once treatment is stopped unless supplementation is continued. There's enough evidence for that as well, which I'm not showing because of limited time available to me. However, there are certain conditions which do require vitamin D testing and supplementation or treatment. And these are the situations which are more vulnerable to vitamin D deficiency. These include non-ambulatory states like cerebral palsy, neuromuscular disorders, CKD, CLD, malabsorption states, long-term use of drugs, especially glucocorticoids and anti-epileptic drugs, and occasionally disorders with extensive cutaneous involvement. Now, in all these conditions, not only is vitamin D deficiency more likely, but concomitant vitamin D deficiency can also worsen the disease-related morbidity in these conditions. We should keep in mind that dose required for treatment and preventive supplementation may vary among these conditions and even among individuals with the same condition, and I'll show some evidence of that subsequently. Therefore, when we are treating these individuals, whether we are treating them for deficiency or we are supplementing them, periodic monitoring is required to prevent toxicity. So this is one of the works we had published where we studied the effect of two risk factors, impaired ambulation and anti-epileptic drug intake on vitamin D status of children with cerebral palsy. So what we found, we actually took 5 groups of children. So one was a healthy control. There were 4 groups of children with CP. One of them were CP and ambulatory. Second was CP ambulatory but on anti-epileptic drugs. And third group, CP not ambulatory. And fourth group, CP not ambulatory and also taking anti-epileptic drugs. And finally, the control group. So what we found was that serum 25 hydroxyvitamin D levels in the ambulatory children with cerebral palsy was not significantly different from the control group, a little lower but not statistically significant. When the child had one risk factor, either non-ambulation or use of anti-epileptic drugs, the levels were significantly lower. These are in nanomoles per liter. And if a child had both non-ambulation and use of anti-epileptic drugs, 25 OHD levels were the least. And corresponding changes were seen in PTH and ALP levels as well, thereby indicating that all children with cerebral palsy do not have the same requirement for vitamin D. And it would, depending on the risk factors present, and of course, another factor would be the dietary calcium intake that we have talked about earlier. The requirement may vary. Another work, which was open label RCT in children newly started on anti-epileptic drugs, we gave 60,000 IU vitamin D per month, which comes to 2,000 units per day for 6 months. The second group did not receive any supplementation. And we compared the 25 OST, PTH and ALP at baseline and 6 months down the line. So what we found was group A was the one who received vitamin D. Group B did not receive anything. Look at the lowest line. The children who received vitamin D, there was no difference in 25 OHD levels. Here it is nanogram per ml from the baseline to follow-up. They remained same. Whereas children who were not supplemented showed a significant fall in vitamin D levels. Likewise, PTH and ALP levels remained same in the supplemented groups. There was no significant change, while ALP and PTH levels showed a significant rise. Again, what it indicated was that when we gave 2,000 units per day, it kind of maintained the pre-treatment vitamin D level, but it did not correct the pre-existing vitamin D deficiency. So if these children were deficient earlier, that deficiency would persist. Just a few words about monitoring vitamin D therapy. When we're treating symptomatic deficiency like rickets, we should assess a response by a radiograph. If it's rickets, a radiograph at 4 weeks would indicate if healing has started, and another one at 12 weeks would indicate if healing is complete or whether further prolongation of therapy is required. Likewise, normalization of calcium phosphate ALP at 12 weeks would indicate a response in nutritional rickets and also indicate the need for continuing therapy. If there is no response or the response is inadequate, in that situation, we must measure 25 OST. And that would help us differentiate cases with non-nutritional etiology and would also, in cases of nutritional rickets, help us to decide the need to continue therapy. Also, all patients who require high-dose supplementation, we talked about the high-risk situation, should be periodically monitored so that the levels of 25 OST can be maintained in an optimum range. As I mentioned earlier, the requirement of each child may vary from that of the other. So one would like to prevent toxicity as well as maintain 25 OST in the optimum range. And also, if we do end up having a child where 25 OST levels go beyond 100 nanogram per ml, in such a situation, we should watch out for hypercalcemia and hypercalcemia. Last couple of slides. Please remember, vitamin D is, after all, a drug. It is not a harmless supplement. Please use it with caution. We, all of us, as the vitamin D testing and the role of vitamin D is implicated in every kind of disorder under the sun. So we are increasingly seeing vitamin D toxicity. It can lead to acute renal failure, nephrolithiasis, and nephrocalcinosis, leading to CRF. It can also give rise to cardiac arrhythmias apart from GI side effects. Please keep that in mind and certainly avoid repeated vitamin D megatherapy in cases of rickets. And finally, all this about vitamin D, but please do not forget calcium. There is enough evidence in India and abroad, across age groups, across different socioeconomic status of individuals, that calcium intake of children and even adults for that matter is low. So while we are talking of optimizing vitamin D levels, we must also ensure that our patients have optimal calcium intake. That is all from my side, friends, and thank you very much. Ganesh, you're not audible.
Thank you, Professor Anju Seth, for covering this extensive topic in a very crisp and very nice manner. You've covered skeletal as well as extraskeletal manifestations of vitamin D, symptomatic as well as asymptomatic vitamin D deficiency, and on the other spectrum of it, vitamin D toxicity. I think you've summarized all the takeaway points. There are a couple of points I think that I would like to just repeat or re-emphasize, I would say. Vitamin D deficiency when children come with seizures and particularly dilated cardiomyopathy. I mean, seizures, at least if you get hypocalcemia, probably one may look for its causes. But hypocalcemia is often not thought as a cause of dilated cardiomyopathy in infants. So I think that is one very important reversible and treatable cause of dilated cardiomyopathy. And secondly, seizures in adolescents. So just like hypocalcemic seizures in infants, it could also present with seizures in adolescents. So these are very important takeaway points. As you rightly pointed out, as the knowledge of vitamin D deficiency has increased, so have the number of formulations and similar sounding or look-alike, sound-alike kind of formulations have increased rampantly. And often these lead to polypharmacy or vitamin D being prescribed by multiple physicians. Also, injectable vitamin D being abused or misused. And that leads to increased risk of toxicity. So thank you very much for it. Very useful. I think we would like to conclude this plenary session now, and we can move on to the next session.
Thank you.
Over to you.
This meeting is being recorded.
everyone. Thanks for attending this session. This diabetes symposium. From the GPED, different voices to this table for a global discussion, to have a global overview. This session, as I was saying, is on diabetes, and we'll have 3 impressive speakers. First of all, we will have Dr. Graham Ogle. Dr. Graham Ogle is a pediatric endocrinologist from Australia, and he is the general manager of Life for a Child program. And he's a professor at the University of Sydney. And just to remind you that Life for a Child started in 20, and now it supports care of more than 58,000 children and youth living with diabetes in more than 50 under-resourced countries. And the program's vision is that no child should die of diabetes. His research interests include type 1 diabetes, epidemiology, as well as access to care and other issues related to diabetes. He will present his talk on human insulin versus analogs in resource-constrained setting. So please, Dr. Graham, if you don't mind, you have... Okay. Dr. Graham Ogle, please.
Thank you very much, Suzanne. And I just wanted to thank JP and everyone involved at GPED for this invitation of this marvelous session. It's just so exciting to see so many online and to scroll through the names and to see people I know and people I don't know from all over the world. So it's my pleasure to talk to you this evening on human versus analog insulin priorities in resource-constrained settings. And Suzanne, the PowerPoint is clear, is it? All well?
It is perfect, Dr. Graham.
Good. Thank you. All right. Now, potential conflicts. The Life for a Child program of Diabetes Australia does receive non-salary financial support and also insulin donations from Eli Lilly. And much of this presentation is unpublished data, so please do not take photographs or screenshots during this presentation. In brief, I will talk about long-acting analogues. Are they better? What have the studies shown? What's their costs? What's the essential medicine list attitude? The current studies that we and our partners are doing and the use in LMICs. And then talk very briefly about rapid-acting analogues. And I'd like to acknowledge David Baran and Kim Donoghue for some of the slides in this presentation. So this is the Life for a Child level of care paradigm. And some of you will be familiar with this. Minimal care, the pink level, results in terrible outcomes, and the comprehensive care, the green level of care with analogs and pumps and CGMs and AIDs results in very good outcomes, but it's also very expensive. So for some years, Life for a Child has been proposing an intermediate care level of human insulin, preferably basal bolus with blood glucose testing, diabetes education, skilled healthcare professionals. And the question tonight, my time, it's just after midnight here, but I know it's all sorts of different times for you, is should we add analog insulin in there? Basal, not just the basal bolus regimen, but analog insulin. And I think we're all familiar with the normal insulin secretion, but our pancreases are very good at giving us just the right amount of insulin that we need to meet the sugar coming into our body. And so this is a typical Western insulin release, if you like, with 3 meals a day. And you can see that the body puts out insulin, but it's a very sharp peak just to look after the meal. And then we do need insulin all the time as well. And so there's a basal insulin secretion going on. Now, these are the periods of action of different types of insulin. And if we look here at the short-acting insulin, this is meant to replicate the meal insulin, but of course it isn't sharp enough to actually replicate that. And then if we don't use analog insulins, for the intermediate acting insulin, we have this curve where there's too much insulin at one stage and then not enough unless you give another dose. And so it's a little bit of a tightrope. We've done very well with it over years, but it isn't perfect. And you can see that the long-acting analog insulins in red, glargine and detamere, are able to give a much smoother, longer period of action. And so they're now standards of care in the ISPAD guidelines, the ADA guidelines. They have several advantages over human insulin with a lower peak, a longer duration of action, a lower number of required injections, and a reduction in severe nocturnal hypoglycemia. But there's an inconsistent evidence on glycemic control, and they're much more expensive, 4 to 7 times. They have been included in WHO's Essential Medicines list in 2021. So are they more effective? Well, the studies, one meta-analysis suggested a 0.4% improvement in A1C. The Cochrane review said essentially there was negligible improvement. Hypoglycemia, most people agree that there is a reduction in severe hypoglycemia, especially nocturnal. There is some quality of life data, not as much as you would think there should be, but there's benefit in some quality of life domains. The patients like it, people living with diabetes. There is less weight gain. And in high income countries, they're cost effective because of the reduction in hypoglycemia. But they're also a lot more expensive. And this is data from David Baran and Mark Ewan and the Health Access International Group. And you can see that human insulin on the left-hand side is a lot cheaper at every level of the health system than analog insulin on the right side. Although they're actually not that dissimilar in terms of cost of making it, it's all the other costs that add up, the marketing costs and the distribution and all of that. Essentially, it doesn't cost too much more to make analog insulin, but the prices are much higher for all sorts of reasons. Now, the WHO Essential Medicines Committee looked at analog insulin in 2017 and 2019 and said, well, yeah, there's some benefits, but it's too costly. And they said no. But then they looked again in 2021 and they said, well, yeah, the benefits are small, but given the hypoglycemia, they said yes. And so analog insulins are now on the essential medicine list. But of course, do governments follow the list? Can they afford to follow the list? That's the big question. So what data do we have from the less resource world? Actually, there's very little data in terms of observational studies or randomized controlled trials. And as we know, they're very different situations, one from another, and they're all very different from a high-income country setting. Now, long-acting analog insulin became available to Life for a Child a couple of years ago, so we and our partners decided to obtain some data. And so we have various studies happening or finished, and I'll talk about the first 3 on this list in particular tonight, a randomized controlled trial in Mali, an observational study in Pakistan, another one in Bangladesh, and we're still analysing the data from Tanzania. And then there's a larger study, another randomised controlled trial, which I'll mention as well, and I think Dr. Zabin will also mention, and Dr. Mali as the evening goes on. So firstly, the study in Mali, this was done with Santa Diabet and also the universities of Geneva and Luxembourg and Life for a Child. It had 260 youth aged less than 25, had diagnosed for over a year, no prior use of analogues, aged 3 to 24 years, 60% were female, and they were nearly all on 2 injections a day of NPH&R or mixed insulin. A couple of them were on a few of them were on a basal bolus regimen. And they were randomized 1-to-1, so 130 in each group. So the intervention group was switched to basal bolus regimen with biosimilar insulin glargine via reusable pen. And it's important to note that they still needed 2 injections with vial and syringe every day, as did the controls. So there wasn't really, the pens was an added injection, if you like. It wasn't as if we were replacing syringes with pens. We had an extra pen injection. And we followed them at baseline and then every 3 months for 12 months. And the results were quite startling, actually. They're wonderful. In the intervention group, the A1C fell, as you can see, but there was a large difference in the control group. The results the HbA1c came down, but in the control group, there was a marked difference from 11.7% down to 8.1%. Remarkable. And so a lot of these young people were not well controlled when they started. And so when you look at it in a different way, this dark blue shows those who were at the high limit of the Siemens machine, over 14%. And you can see that by the end of the study, none in the intervention group were at that level, and 15% were less than 7%, and another 27% were less than 7.5%. While in the control group, there was some improvement, but not nearly as much. And there were also decreased episodes of diabetic ketoacidosis. The two groups, despite the fact that they were randomized, weren't quite equal on that metric at the start, but there was a lot less cases of diabetic ketoacidosis in the Basaglar group, the intervention group, but not so in the control group. And indeed, there were 2 deaths in the study period, both in the control group, both from DKA. Now, there wasn't any increase in episodes of severe hypoglycemia or decrease, but there weren't that many episodes to start with, but we didn't see any change in severe hypoglycemia. And these are some of the quotes from the young people. And they really, the first time I read these, I had tears in my eyes. But you've got a young man who's working in a garage who can now loosen the wheels of big trucks where he couldn't do that before. A lady who's filling up water and used to have to do it slowly taking breaks, but now that she can. Another lady who couldn't go in the bus to the market because her sugar levels were too high and she was weeing all the time, but now she can. A young lady, a boy who says that the doctors are no longer yelling at my parents and feeling normal, and the boy who talks about how that he can do soccer training now again. And it isn't surprising, isn't it? This is looking at long-term complications, and if you look at severe long-term complications of green, the blindness, and the blue bars, renal failure, you can see that if you reduce the A1C down, long-term complications are markedly reduced. And what these young people were talking about obviously was just the effect of short-term or sustained blood glucose control in their lives. Now, the Bangladesh study, which was done with Dr. Bedora Zabin, who's speaking this evening, and the Burdham Institute in Dhaka. This wasn't a randomized controlled trial. It's an observational study, 193, so a big number. And the A1C in this group was much lower. This was a group looked after in Dhaka by Burdham, not a regional group, but a city group. But you can see that the A1C still had a substantial decrease from 8.3% to 7.8% at 12 months. These are preliminary results. And again, there was an improvement. If you look at the numbers of young people achieving a target of less than 7.5%, it was 31% at baseline and 49%, great results at 12 months. For Pakistan, again, these are preliminary results, and this is with Dr. Ashraf Fawad and the Bakai Institute of Diabetes and Endocrinology in Karachi. Again, a large number, and the A1C decreased from 9.7% to 9.0%. I think the N might be wrong there, but it's a large N, somewhere between 100 and 200. And so, again, thinking about the complications, even when you're looking at A1Cs in the 8s and 9s, every improvement that you make reduces the risk of long-term complications. And then there's another study underway, the Human 1 study, which is a large partnership, and I think Bedora will speak more about this, between the University of Pittsburgh, Burdham in Bangladesh, the Tanzanian Diabetes Association, Life for a Child, Harvard, and the Clinton Health Action International as well. And this is looking at the question, and the particular edition of this study is CGM and time in range. And I won't spend much time on this, but you can see that there's, again, there's two groups with a very large number, 400 for the two countries, and there's CGM at certain periods as well. So that study is now fully enrolled, and we will know results in due course. So what's making a difference in these studies? Is it just the change in insulin? Or is it a change from twice daily to basal bolus regimen? Or is it the education and encouragement and increase in motivation? Now, in all these studies, we tried to keep that the same, but still, it's very hard to tell, isn't it, exactly what's making the difference. But there is a difference. And so, should government purchase of long-acting analogues be encouraged in LMICs? Well, you can make a strong argument for yes, because they're more effective, and so you're going to have more productive people living with diabetes who are healthier with less complications, and you can see the results there summarized. Now, from these studies, it would suggest that the benefit might be higher in LMICs. But again, a question is how much is due to the insulin itself or changes in regimen and education? And it's clear that the impact is very situation dependent, but still there's an impact. But another way of looking at it is that there's limited budgets, both for governments and families. And so it depends on the country. And thinking about a country where there's a limited insulin budget, which is inadequate for the population, then if you buy analogues, then you can only afford to buy a quarter or less of the insulin that you had. Or if you've got insulin coverage, but no coverage for test strips or A1C, what is the priorities? And David Barain expressed this very well in a debate at ISPAD in Abu Dhabi. He talked about a hypothetical low-income government setting where if they bought analogues, it would be $266 per year more expensive. Now, if the government isn't providing self-monitoring, if the government hasn't set up decent diabetes clinics, which would you choose? Would you choose analog insulin or would you choose the others? And so what can happen is the government might just buy less insulin, or you need to decrease expenditure in other areas. And then there's the cost of switching as well. So there isn't necessarily a right or wrong here. It depends on the country. And then David also looked at the costs for families. And if a family's buying these medicines, and this is what often happens, and I've often heard of families who are seeing a private doctor and they're paying a lot for analog insulin, but they're hardly monitoring or not monitoring at all. And that is not good medicine to me at all. And if you look here, they're buying a vial a month. And if they're earning $76 a month, it can be, the difference is $4 to $31 potentially for the family. And it's between 6% and 41% of the total family income. So we have to be very careful about what to advise our families. And so it does depend on the country and the GDP and how far that country's progressed with universal health coverage. And my view is if the government can provide self-blood glucose monitoring and diabetes education and can also afford analog, absolutely yes. But if not, there needs to be focused on the missing components first, and we should do basal bolus with MPH and regular. Unless the price can come down. If the price can come down, then there's no problem. Or there's donations. If there's donations available, then it's a much easier argument as well. And Life for a Child has developed switching guidelines from MPH and regular or mixed insulin to glargine biosimilar and regular. And if you'd like a copy of those, please contact Life for a Child and we'll send them through to you. So just talking briefly about rapid-acting analogues, again, back on the levels of care. Again, their standard of care. They have several advantages over human insulin and that they permit injection closer to the meal time and they have a shorter period of action, as we saw, which is more physiological. They're the insulin you use in pumps, but again, they're more expensive and they're not in the WHO essential medicine list as yet. And we talked about this before, but you can see that the rapid acting one is much more like what the body does than the short acting one. Are they more effective? Well, I'm not an expert in this data, but from my reading, it appears that there's a small fall, a very small fall in postprandial glucose levels. There's no change in A1C. Some studies suggest less hypoglycemia, some don't. It's definite that the families prefer it because it makes meal times more easy and that sort of thing. There's definitely a preference, and this is important in its own right as a factor, but it's definitely preferred by families. But there's not much happens elsewhere in terms of a clinical benefit. So, and are they more expensive? Absolutely. Are they on the essential medicine list? Not yet, but there's actually an application in for this to be reviewed right at the moment, and we'll have to see what happens there. What data do we have from the less resource world on rapid-acting analogues? Very little. And so should government purchase of rapid-acting analogues be encouraged in LMICs? Well, again, my answer is if other components of care in place and the funds are available, yes. But otherwise, no. And the focus should be on other components of care. And if you gave me the choice, and we did have the choice a couple of years ago between long-acting analogues and rapid-acting analogues, I would choose, as I did then, long-acting analogues. And finally, Life for Child. Many of you would have heard for Life for Child. We're helping in many countries. If you think that you're in a situation where our program could possibly help you, please contact us through the website. And thank you very much for listening. I'm very open to help with any questions.
Thank you very much, Dr. Graham, for this beautiful talk, which raised difficulties of management of diabetes. So I have the opportunity to ask my own question while waiting for the question of the attendees. So my first question, as analogs are now in essential medical list of WHO, if it's manufactured as a generic, should the discussion be different? Because finally, it's as in difficulties of management of diabetes is more political and financial decision. What do you think
absolutely,
about that?
yes. And generic forms are available in America now, and that's brought the price down, although the prices in America are still ridiculously high. But unfortunately, Suzanne, it doesn't necessarily bring the price down very much. There is pressure, there's some pressure, some competition, but still, if it's 3 times more expensive rather than 4 times expensive, would you use it? Is it? And that depends on the government. I find it terrible that families are spending all their money on analog insulin and not spending money on meters and strips. And as well, that they to strengthen the diabetes services and diabetic than analog insulin. But if those other factors are in place, then of course, let's do it.
I have another comment from...
As similar, the prices will come down.
Perfect. I have a second comment from a colleague working in South America. He's asking rapid analogs and food with a high level of fat. In the observational study, it seems that it's better to use Act Rapid better than the rapid analogs. What do you think about that?
I'm not sure that I fully understand the question, but I think rapid acting analogs, as long as you know what food you're going to eat, well, you need to know what food you're going to eat for either rapid or rapid acting analog is best. You should always take the insulin before the meal, but it does give you more flexibility because you can have this at the question. But
Sure. You have another question from Dr. Diane Stephanie, data of use of rapid analogs and NPH mixing.
I don't know.
Did you get the question?
Yes, I did. Yes.
Hello?
Yeah, I would.
Hello?
Can you hear me? I think I did hear the question. I'm not sure if there's any data on rapid netting analogs and NPH.
Yeah, it was just that we had. Okay. So you answered the question. Okay, these are the four questions that you had in the chat. Thank you very much, Dr. Graham. I think we will let you go have some rest.
Thank you. Have a nice meeting, everyone. Thank you, Suzanne.
And thank you so much, Dr. Graham. Thank you.
Thank you. Bye.
We will now go to our second speaker. Our second speaker, Dr. Bedora Zabin. Dr. Bedora Zabin is a pediatric endocrinologist from Bangladesh. She's a secretary. She's a member of ISPAD, and she's doing an incredible work on diabetes. So I don't have a minute to say everything about her because she is leading one of the biggest suite center with more than 8,000 registered young diabetic patients. She will draw our attention on the use of diabetes technology in resource-constrained scenarios. So if Dr. Bedora Zabin is ready, she has the floor. Dr. Bedora, you have the floor, please.
Thank you so much, Dr. Susan, for your kind introduction. Good evening, everyone. It's a great privilege to speak in such a global platform, and I should give thanks to the GPED organizers for creating such an impactful experience for all of us. So this is my topic. I have nothing to disclose. So we all know about diabetes technology is rapidly evolving, providing individuals with diabetes innovative tools for monitoring blood sugar, for education and treatment as well. Diabetes management, particularly for children, relies on advanced technology to monitor blood glucose levels and deliver insulin accurately, of course. However, many regions, as we have seen in my previous speaker slides, that face significant barriers such as high costs, limited infrastructure, and lack of trained personnel. So next 25 minutes, I will talk about the overview of technologies, challenges we have in low resource settings, experience in our pediatric diabetes center in Burdham, and some case studies, some innovative solutions and adaptations in our center, and experience with advanced technology in minor context, of course, in our center, and summary and conclusions. So we all know about that the insulin delivery system starting from syringes, pens, and then end up to insulin pump, and the blood glucose monitoring system starting from glucose meters. We always do with that, and then continuous glucose monitor, mobile health apps, and telehealth, of course. If you look into the benefits, yes, CGMs provide real-time glucose readings, helping users track their blood sugar levels throughout the day, which is very important for type 1 diabetes, who are taking 3 or 4 times insulin. And definitely they can adjust the dose accurately as data-driven insights can be seen There is always flexibility in dosing in analogs, precise insulin delivery with the pump. Lower glucose variability, reduce risk of hypoglycemia, because always there is chance of hypoglycemia in type 1 diabetic children. And definitely it is convenient, which helps in improving the quality of life. So what are the challenges we face in low resource setting? Almost most of the countries where we are working having the same challenges, starting from the infrastructure limitation, because there is always difficulty in access to healthcare facilities. Limited access to technology is another challenge, training and education of healthcare professionals. And of course, there is always a social challenges, social stigma, socioeconomic factors which affect the technology adoption as well. If you look into these slides, that's the management of type 1 diabetes in low and middle income countries. In different countries, we can see different perspectives, starting from insulin. In some countries, it is 100% available, but in some countries, we can see this not available frequently. Same with the syringes, with the blood glucose monitors, and also the strips. In some countries, we can see even there is no strip is available. And we always know this is very important with the type 1 diabetes. When you are giving insulin, the monitor should be there. Always we have to monitor for the better management of the type 1 diabetes children. So I will just share some experiences in our center. And as you know, that Diabetic Association of Bangladesh is working like an extended hand of government, and we have 135 affiliated associations throughout the country. And in our center where we are working in the Burden Hospital, it's a tertiary care hospital. And we have the Center Pediatric Diabetes Care Research and Center, which is, of course, collaborated with the Changing Diabetes in Children and Life for a Child. And also we have some government support, and also we have some paying patients. If you look into this pie chart, you can just see that only 8 to 10% of patients who can buy their insulin on their own or afford the insulin management and type 1 diabetic management on their own. So more than 90% are having free care from our center. So human insulin is the major insulin in our center, and the second one is the analog. Very few paying patients can afford, and less than 1% of our patients are using pump on their own. Limited access to technology, that is blood glucose monitoring. More than 70% of patients are having free glucometer with strips throughout the SCDS and LFSC program, and 29% of our patients who can afford their own, or very few patients who cannot use, actually they're not wanting to use the glucometer or strips, so they're not using. That's a real challenge for them. If you look into the patient's SMBG, you can see this is such a good self-monitoring blood glucose. These patients are doing multiple SMBG at home, and it's very good control. This one in another one is having the hypoglycemia every day. Another one is hyperglycemia most of the time. Here we can see the hypos and hypers. As a pediatric endocrinologist, this is very common, we know, with our type 1 diabetes while using the human insulin. And this is another one is hyper and hyper, and this is almost everyday hyperglycemia is the patient is having. So just few case studies. We are using the human insulin like more than 15 years. This boy developed type 1 diabetes at the age very early, that is 8 years, 3 months old. And he came to our center after 5 months of diagnosis. He was already on insulin. And we started with the dose of 1.2 unit per kg. And regularly the patient came for follow-up. We gave the education, dietary education and counseling. And currently, if we look into his blood sugar, it's normal after 15 years. A1C is very good with the human insulin, and there are no microvascular complications. So you just look into this graph. That's initially it was like this. Then again, it's raised up. Again, when he became adolescent, it went up. And then now for last couple of 3 years, when he's a young adult, having good control with human insulin SMBG. It's having high blood sugar, of course, A1C is 12.3%. He was diagnosed at 11 years old and with the regular and NPH insulin, and can see it's high all through. And it came down during COVID time. First, I think it came down to below 9%. And for last 1 year, he's on basal analog insulin, and you can see that the A1C came down to 7.5%. So it's a long journey, and there is as well, there are no microvascular complications as well. So what we can do with our low resource setting, we have to enhance that. So we can enhance our multidisciplinary team with the training focusing on type 1 diabetes. We can try for free comprehensive care for all underprivileged children. Education, structured education program we should start on, what we have started actually, and dietary education, special counseling program, telehealth, and educator model. So this is what we are now practicing, that self-efficacy, diabetes management, personalized care to improve the glycemic control, even you are on human insulin. And this is the dietary education for effective type 1 diabetes management. Now we are in the tertiary stage of education with carbohydrate counting, everything. The most problem is in our setup or in our countries that most staple food is the carbohydrate. So this is a real challenge for clinicians, for dietitians, educators as well, to manage a type 1 diabetes. And of course, mental health is a big issue globally and throughout the world, I should say, and also in the Southeast Asia and Bangladesh as well. So we are focusing from the beginning with the symptom-based psychotherapy, psychological assessment in every child who is coming to our center, and then the counseling with the group session with the caregiver and patient, also individual session. It's very important nowadays that peer group intervention, and our children who are grown up now, they are doing the advocacy. They have built up a project, the DREAM project. They are giving the small group education, counseling, access to phone for emergency situation. They are working with that. They are trying to build up awareness in the community through the camp, through the school programs. They are working as a young leader in IDF, and also they have social media, a group for communication and telemedicine platform. We know this is from the COVID time, it's working so well in every country, I think, having now the mobile and follow-up with the online follow-up with the giving the routine advice. They can, anytime our patients can have the emergency access. If they become sick, they can call our educators or our dietitians or our team for the emergency access. And also they cannot coming to the clinic personally, they have the access to the mobile. And as because we have a large majority of patients are outside from Dhaka, so we are now expanding our care in the peripheral centers. First of all, we tried to visit, then did some CME programs with the healthcare professionals. Then we identified the number of patients of type 1. Then we focus in 6 centers with collaboration of CDIC program. And now we have provided the trained educator to these centers and building an educator model for the peripheral centers in Bangladesh. It's a study we did a few years back just to see the effect of structured diabetes education program. Within 3 months, yes, we just followed up the patients, and then we see the impact that yes, the A1C is going down. This is another data from our 1,007 patients who came regularly last year, and we tried to focus on how many times they're doing this MBG. So we found that, and we tried to make the association with the A1C. So who did the once daily SMPG, we found the mean HbA1c was 8.4%. Who did 2 times daily, the A1C in those patients were 8.5, almost similar. Who did the 3 times or more, we got the A1C was reduced more significantly. And during COVID time, as we have started the telemedicine, and in 1 month we got 645 calls and 235 patients were consulted over phone and video call, which really worked very well, and we are still continuing this support in our center. Always we look into the metabolic control. What is your A1C in the center? So if we look into from 2015 to 2021 is around 800 regular patients. The main thing we can see from this slide that the patients who are in the more than 9%, the high number is going down, less than 7%, a little going up. The more significantly, the 8%, around 8 to less than 9% patients, it has been increased, the number is increased in our center. And from the 2010, patients, if we look into mean A1C, from 2019, I should say that ultimately, after struggling with more than a decade, that we could make it down, the A1C, from 9% to around 8.9, and now it's last year it was 8.3%. And if you look into the severe hypoglycemia, the acute complication is going not very high, only 0.2%. And if we look into the diabetic ketoacidosis, it's also very low in number, I should say. It gradually is going down. Now the experience with advanced technology. As my previous speaker, Dr. Graham already mentioned that the Life for a Child has taken a great initiative of the introduction of new analog insulin from 2022 from Bangladesh, and 40% of our patients will have this analog insulin. And from this year, the main change is that all the patients from the syringes, even they are in human insulin, regular NPH, they are switching to pen since this year, January this year. Just a case scenario, switching to basal analog. You see, it was so high, the A1C, and from January, we have started the analog insulin. And we can see how it went down from 13 to 8.2% in last month. Already, Graham has shown that we have started this observational study, but already we have completed it, and the data analysis on progress, and already Graham shown that how A1C was reduced in this study. At the same time, we saw that some quality of life, even impact of this analog insulin on quality of life. So in youth with type 1 diabetes, that is 200 patients around, and we used the 22-item short form of diabetes quality of life in questionnaire. And we evaluated also 6 months from baseline and then 12 months. After 12 months, we found the total quality of life score was significantly improved, including the impact score, but parents' issue score or worry score was not improved even in 12 months. So it was presented in last DISPED meeting as poster. And Graham also talked about it. This is a real challenge to start with, and already we have finished our first randomized clinical trial in Bangladesh, and our last patient follow-up finished in last month. We are now looking forward to Tanzania because it will finish by January, and then we'll go for the analysis. That was done with the blinded professional CGM, with looking into the time in range and severe hypoglycemia in 2 arms. One is the basal analog insulin, and another one is with the human insulin. That was a real challenge to start with the CGMs because, always new thing, to adapt new thing is always a challenge. But we could start with different mode of interactions. So hyperglycemia is always a challenge. You can see that in this case, we had 21% of patients having severe hypoglycemia and 61% had time in range. And other patients, these are all non-RCT patients. We could do the CGM in some patients in Bangladesh other than RCT patients. Here is also hypoglycemia, another challenge. We know that hypoglycemia, nocturnal hypoglycemia is always common in our setup. So this is another one to improvement. This is a patient with type 2 diabetes but having high blood sugar because the main thing was she was not compliant to, or adherent to the treatment, and also the missing the doses sometimes. So you can say how much hyperglycemia. She was having 72% hyperglycemia. And after showing her blood glucose pattern, after 1 month, when she did her lifestyle change and took her insulin regularly, you can see how it improved the time in range after 1 month. And of course, we know that with the pump, pre-pump and post-pump, this patient had time in range is 45% and it improves after almost pump given for 1 month. So. And this is the poster we presented in last month in ISPAD meeting. We just tried to look into the glycemic variability in 3 groups, human insulin analog and pump group. You can see the time in range was almost similar, a little improvement in the analog one. The time above range was also same, only there was the glucose variability was high in human insulin and it was low in the insulin pump significantly. So in summary, that if you enhance multidisciplinary team care approach, simple approaches like education, healthy eating, regular exercise, and strong emotional support can make a significant difference in your patients. Low-cost solutions like emphasis on existing diabetes, because we have human insulin, we have now SMBG. If you improve it with the mobile health, with the educator model, yes, it's possible to have a good glycemic control and good quality of life in your patients. And always encourage ongoing research and collaboration and advocacy to support to ensure access to necessary resources and technologies. So in conclusion, by focusing a strong support network, caregivers can enhance the well-being of these children and help them manage their conditions more effectively. Technology matters, of course, we have seen, and its thoughtful application is required to enhance the quality of care and support in young people with diabetes. And embracing a something is better than nothing approach and strategic implementation can significantly improve health outcomes for individuals with diabetes in resource-constrained scenarios. So we must think about to improve the lives of children with type 1 diabetes is possible, even without advanced technology, but with a dedicated team, of course. Thank you all for your patience hearing.
Thank you very much, Bedora, for this brilliant presentation. Thank you very much. The data are very interesting. I have some questions for you. I will go. Okay, somebody said a patient doing very good with all that we are saying, insulin and the self-monitoring glucose education have more than 3,000 injections per year. Do you think the use of CGM may help in their metabolic control and even quality of life?
Yes, as I have shown that some patients with CGM we could do other than RCT patients. And you see, I think I have shown also a type 2 who is having high dose of insulin, how the hyperglycemia was improved. So if even we don't have the analog insulin, but if we have the continuous glucose monitor, I think as a clinician, we do understand this very important is the hypoglycemia in type 1. Sometimes the patients don't understand they're having nocturnal hypoglycemia. So unless you do a CGM, you cannot show them or you cannot take a decision to, the change of NPH dose or whatever during the night time. The same thing happens when they are having hyperglycemia as well. So sometimes they don't want to go for, I have shown that some patients are doing very good. I'm sure in all aspects is possible. They are doing the regular self-monitoring blood glucose, but some patients, they don't like to do even. So if you have CGM, yes, it's a good solution, I should say, in my experience for last couple of years.
Yeah.
It should be available in low price, in low resource settings.
Yes. We have another question.
Yes, sure.
From Vena. What will be the best time to check postprandial sugar on short-acting analogs? I think it was for Graham, but you will take that one also.
For the short-acting analog, the postprandial blood glucose time?
Yeah.
Blood glucose time. When we to do?
Blood sugar.
When you have to do it?
The best time,
like
do you think is an hour or 2 hours?
Oh,
like
ideally, yes,
insulin?
I understand. Ideally, we advise for 2 hours. But if you have young children with type 1, if they're prone to hypo, sometimes, yes, you can do for the adjustment. Initially, you can go for the 1 hour, whether they're having hypos. Yes, you can. But ideally, it should be by 2 hours. But for young children, yes, sometimes we have to change like 1 hour. Yeah. Not audible. The sound is not audible.
Sorry, I was on mute.
Yeah, now I can.
Yes, I have another question for you.
That's okay.
If you have the possibility, no financial constraint, what, from your point of view, is the difficulties to put technologies in low resource setting? You think the difficulties will be at the level of healthcare professional to teach them, or at the level of patient, or what do you think?
Well, first of all, when you want to develop a pediatric diabetes care, you have to have infrastructure, and then you should have the trained healthcare professional. You see, I have shown you that 8% of our patients are having their own insulin. They are using the pen and palm. So in the same center, we are having the everything like advanced care and also the traditional or conventional method. So you see, the training is not a big problem. The problem is always the financial. Definitely, it's not possible for them to go for analog or CGM at this moment. Maybe if the price is low, yes, it's possible. So first of all, you should focus on your country or your perspective, where you are, where you want to go, and how. So first of all, you need a good trained healthcare professional, a dedicated team for pediatric diabetes care. That is possible for introduction of new technology, of course, in your center. Thank you.
Thank you very much, Dr. Zabin. Thank you for the incredible work that you are doing in Bangladesh and for the experience that you share with us. Thank you.
Thank you so
We'll
much.
We'll now move to our next speaker, Edna. The third speaker of this session is Edna Majaliwa, and she will share about diabetes ketoacidosis management using subcutaneous insulin in children. So who is Edna Majaliwa? She's a pediatric endocrinologist from Tanzania. She's working in the Muhimbili National Hospital, and she's the founder of Pediatric Diabetes Clinic in Tanzania since 2005. She's an ISPAD member. She's also a member of the African Society of Pediatric Endocrinologists, and I will not be able to say everything about her, but she's a very dedicated person in the field of diabetes care in Africa. Edna, if you are ready, you have the floor.
Thank you very much, Susan. Good evening from this side. Good evening, everyone. Thank you, Susan, for the nice introduction. And I would like to take this opportunity to thank the organizers for the opportunity to present on management of decay using subcutaneous insulin. I have nothing to disclose, and this is my outline. So the introduction, I won't be talking about DKA in this community. I know everyone knows about DKA and what are the prevalence. It's about 15 to 70% in developed world. But when you go to the limited resources, like in sub-Saharan Africa, it's 80% or more. And for those who are already diagnosed, it can reach up to 10%. So how do we do our diagnosis? Usually it should be biochemical. So you do hyperglycemia, venous pH, and ketonemia or ketonuria. But then when you're in limited resources, like in sub-Saharan Africa, you may not have the ability to do the acid level, so you may not be able to do the venous blood, the pH. And the only thing you'll be able to do probably will be blood glucose, and you'll have the hyperglycemia, and then ketone in urine and ketonuria. And so you need to classify your decay clinically. And you'll have the mild decay, which where the patient will be oriented, alert, but they'll be fatigued. Or moderates, where they have osmolar respiration, they're oriented but sleepy, and you can arouse them. And when they have severe, they're either in coma or they have osmosis breathing and depressed respiration. So how do we manage? Our aim is to normalize the blood glucose, the fluid volume status in the body, the electrolytes, and the acidosis that has occurred. But doing this, you require expertise, you require a protocol, and intensive care, and then a lot of resources. So there's an utilization of the resources is very high. And what you're doing in the management, there's an initial assessment. You correct the shock if it's present or not. Then you start fluid replacement. Then there's insulin treatment, which we'll be talking about, and potassium replacement, treatment of infection if they're there, and manage or prevent cerebral edema. And then you monitor and transit to sub-Q insulin. So what are you monitoring? You're monitoring the vitals. You're monitoring the blood glucose, fluid intake and output, electrolyte and renal function. Then you're looking at mental status. Like I said earlier, you have to prevent cerebral edema, hypoglycemia, and hypokalemia. So insulin treatments, but ESPAT recommends the slow IV regular insulin use. This is throughout the guideline, even the current one. So, and it's because it provides a predictable fall and you prevent the hypoglycemia. It's not easy to get hypoglycemia when you're using the slow IV regular insulin. And then the acidosis is smoothly resolving. But this regimen requires an ICU, which might not be practical in many resource-limited countries. So, and in that setting, you may need subcutaneous insulin, or subcutaneous insulin may be the only way out in the management. But there are also other constraints, and in limited resources, you may not have expertise. You have shortage of intensive care. You have lack of knowledge in type 1 diabetes, especially when it is in the youngs. and supplies like fluid. Sometimes you don't have fluid, sometimes you have. Sometimes even the insulin is not readily available. So because of these factors, subcutaneous insulin might be the only way out for the management of decay in some setting. But even in settings where there's everything available, patient with mild to moderate decay may use subcutaneous insulin and they use analog to treat decay. And so the different ways in which people use subcutaneous insulin to treat decay, I call them version because they're not regimen, because it's just different centers using different ways of subcutaneous insulin. So, but all these insulin start after the first 2 hours after the initial fluid therapy, like how the standard is supposed to be. So it starts with fluid as the standard treatment, then we continue with sub-Q insulin. So the first version is where they use the regular insulin, 0.5 units per kilo, but then the dose is divided in two. So half of it is given intramuscularly and half of it is given sub-Q. Thereafter, after the 0.5 units per kilo is given every 6 hours until urine ketone is negative and blood glucose is being controlled. But if there's a rapid decline, remember we'll have to decrease the rates. The next dose of insulin is decreased by 50%. So instead of 0.5 units, they're given 0.25 units per kilo. Then you may need to add 5% dextrose. It's reaching 14 to 17. 5% is added in the fluid, like in the standard management of decay. Then there's a second version where we use analogs, and this is not necessarily in the limited resource setting, and it might be in high resource setting because they're using analog, and they start with 0.15 after the initial fluid. Then they give it 2 hourly until decay is resolved. But then if blood glucose falls very fast, it is reduced to 0.1 international unit per kilo, but continue every 2 hours until it's resolved. And by rule, when it reaches between 14 to 17, then you have to add 5% dextrose. And don't forget to monitor your blood glucose every hour. But then there's a third version where 0.13 to 0.17 units of regular insulin is given every 4 hours until decay resolves. But then you may need to increase if someone is not responding, and increase by 10 to 20%. And then if acidosis is not improving every 2 hours, you may increase that frequency because you're doing it 4 hourly. But then if acidosis is not improving, you might need to increase to the frequency to every 2 hours. And then blood glucose monitoring should be 1 to 2 hours, depending on the resources. If there's poor perfusion, then the subcutaneous insulin might not be the best option, and you may need to use intramuscular insulin. So what are the evidence? There have been studies that have been done in different settings where they're comparing the subcutaneous insulin and the normal regular slow IV insulin in management of decay. And Nelamana looked at Lispro and gave 0.15 units every 2 hours after the initial hydration until the blood glucose reached 14. And then another group, he used 0.1 units per kilo. And both groups, the decay was corrected in 6 hours. Then there was another study which involved children as well. And I have very few studies for children because many people did not look children on that. And this had mild to moderate DKA. And one they used ASPAT 0.05 to 0.1 2 hourly. And the other one they used the normal regular insulin, slow IV, and the DKA resolution was similar. They had similar time in the correction of the resolution of the DKA. But then there's another study where Cohen used regular insulin every 4 hours, and based on the dose of 0.8 to 1 unit per kilo per day, and used it every 2 to 3 hours, giving it subcutaneous. So it depends on where you are and what is available to you. But when you look at limited resource setting, regular insulin is readily available than analogs, and it can easily be used in the management of diabetes ketoacidosis. After DKA has resolved, the management that follows is similar to the standard. And in this context, criteria for DKA resolution, because sometimes you may not have, not sometimes, most of the time, you do not have ability to measure ketone in blood. So you're depending on ketone in urine and the patient's clinical improvement. So when they're improving clinically is what decides or what makes you decide which way to go. So you look at the clinical improvements, if they can tolerate feeds, and then the ketone in urine is clearing. Then when they have the DKA has resolved, remember we're using subcutaneous insulin, but the regular one, then we go back to the normal dose, which is adding on the intermediate or the long acting, depending on the availability of the insulin. But remember to check the potassium 2 to 4 hourly, depending on what you have. If you don't have the facility to measure potassium, you may use the ECG machine, which may not be available, and you may depend on urine output. And keep the monitor close by in case cerebral edema happens. This is just a flow chart, so you cannot see it properly, and I leave it to that, but it's just from the diagnosis of DKA and assessment to the treatment of DKA. So what is the take-home message from this? It is IV regular insulin in the standard of care in the management of DKA, but the rapid-acting insulin can be used for the treatment of DKA, and subcutaneous insulin is feasible in limited resource. Then IM regular insulin can be used as well if there's no IV access. And when it's when someone is dehydrated, the preferable way is intramuscular insulin instead of sub-Q. But the standard management remain the ESPAT guideline. And don't forget to monitor the vitals, the glucose, electrolytes, and ketone as necessary and as possible and as you can do. But then once DKA has resolved and they're able to tolerate feeds, intermittent acting insulin, which is readily available, can be administered. Thank you for listening together with Kami.
Thank you very much, Edna. Thank you very much. We are waiting for some question in the chat. There is a question of Nia Sandar. Let me take the question for you. Hold on. Just 1 second. Let me go in the chat. So the question is, I use rapid acting insulin subcutaneous in some cases of DKA. What is your advice for potassium replacement? Should be in the fluid replacement. A question of Mia Sanda from Myanmar.
Thank you for that question. Depend if there's okay, rapid insulin is used in the management of sub-Q, which is fine, and usually it is mild to moderate DKA. And if they're able to measure potassium, that would be best. Then they measure potassium and see if they need to correct. That is on the second hour. But then if they have access to IV intravenous and they have potassium deficiency, then they'll have to correct intravenously. Otherwise, they may use oral potassium if it's available, or foods which contain potassium, depending on where you are and what is available for you. But the best option would be to know how much potassium you have, and if you're able to get an IV line and correct the potassium as well.
So can we say that after the first urine output, in case she is not able to control potassium level, she can add 40 millimole per liter of fluid given?
Yes, if they have access to IV fluid, yes, they should add.
Thank you, Edna. Another question about the time of resolution of DKA under sub-Q insulin. Is it as rapid, okay, let's say as rapid as when you are using IV, or?
Thank you for that question. It is not as rapid, but it's not very far from it. So if unless it is mild to moderate, which will be almost similar, they'll have similar timing. But in a severe form, the the slow IV will correct earlier, but not more than 2-3 hours behind the ahead of the subcutaneous insulin. So even the subcutaneous can do better, but not as fast as the slow IV insulin.
Thank you, Edna. We have a question from Andrew in India. Hello, Andrew. Happy to see that you are here. She's asking, what about nasogastric fluid if you don't have IV line?
Thank you for that question. If you don't have IV line, you can use nasogastric tube for fluids. I didn't mention any fluids because I concentrated only on one arm, the insulin, but then you can give, or because if you cannot access they need fluid, then you can do, not they need fluid, they need fluids. So you'll use the oral way to give them fluids.
Thank you, Edna, for sharing this experience. So another point, so from what we are listening, the level of management of DKA can be even the intermediate care and even low. That means no child should die from diabetes, even if he's in the. You want to make a comment, Edna?
Yes, my comment would be if the low level can be taught, if they have availability of, so what we need here is insulin and the fluid, the first fluid to correct. But if they don't have, we usually use even the ORS can be used in the correction. Then they may use subcutaneous insulin to correct. So even the very low stages of managing decay, and then they refer to the high levels. Yes, Susan?
as if I don't know if I lost you or I'm the one who is lost. There is no other question.
Thank you.
Thank you, Edna.
You are lost. Thank you
Thank
too.
you.
Have a good
I'll
day.
rapidly say what we got from this. So what can we get from Graham Ogle from Life Improve, the metabolic condition of patient and even the quality of life? But it is expensive and the use depends on the country policy. Dr. Bedora Zadin also showed that the use of technologies, especially CGM, improve A1C and quality of life, but it's still very expensive and also depends on the country policy. From Etna Majaliwa, we can get that the DKA treatment is possible in every condition by using even insulin, some cutaneous insulin. She showed a very simple, I would say, guideline or protocol of care of DKA. So we can understand that finally diabetes is a management is difficult depending on financial constraints. To have the better type of care, we need money. We need to have countries that are engaged in the management of diabetes, engaged in the training of healthcare professional and the support of family. We are at the end of this symposium. Let me thank the three speakers. You can clap your hand where you are around the world for Graham Ogle, Bedora Zadin, and Edna Majaliwa. And we also want to congratulate the GPED team, Solène and the others, and Jean-Pierre Chanoine. Thank you very much.
Dear participants, this session has now ended. We will have a quick 15-minute break. We will be starting the next session at 3:30 p.m. GMT. You're welcome to exit this session and choose one of the two Meet the Expert discussions, which will be held simultaneously. One session will focus on the long-term consequences of small for gestational age, and the other will address the evaluation and management of bone fragility disorders in limited resource settings. Thank you, and we look forward to seeing you in the next session.
This meeting is being recorded. 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 This meeting is being recorded.
And book chapters. Additionally, he provides guidance on the management of the children with metabolic.
This meeting is being recorded.
Hello, everyone. I'm Dr. Roberto Bogarin from Costa Rica. To this Meet the Experts session, long-term consequences of small for gestational age. Our speaker today, it's a pleasure to me to introduce him, Dr. Xiaoping Gu from China. He is the president of the Tongji Children's Hospital, chairman of the Department of Pediatrics at Tongji Hospital. He's also the director of the Center for the Diagnosis of Genetic and Metabolic Diseases, and he's dean for the Faculty of Pediatrics at Tongji Medical College. He has quite a long experience in research, and he's also part of many medical societies. He's the vice president of the Chinese Pediatric Society, honorary president of the Chinese Society of Pediatric Endocrinology and Metabolism. He has published more than 60 book chapters and over 570 peer-reviewed articles, and served as editor or reviewer for more than 45 domestic and international medical journals. So it's a great pleasure to introduce him, and I'm pretty sure his lecture is going to be quite interesting for all of us. So Without further ado, Dr. Xiaoping Lu, the auditorium is yours.
Thanks for the kind introduction. I'm Dr. Xiaoping Lu from Tongji Children's Hospital in Wuhan, China. Thanks to JP and the organizing committee for inviting me to join first GPED virtual annual meeting. My topic of today is long-term consequences of small for gestational age. I have no relevant financial relationships to disclose. Small for gestational age is generally defined as birth weight and or birth length and head circumferences of infant that is less than 2 standard deviation score from the mean for gestational age. Based on the reference data, neonates can be subdivided into SJ for weight, SJ for length, and SJ for both weight and length. This helps to understand the mechanisms and effects of being born SGA. Currently, birth weight is the most often used reference data to define SGA newborns. The prevalence of SGA is approximately 10% in developed countries. It is reported as high as 41.5% in South Asia. In China, the estimated prevalence of SGA is 12.8%. Maternal, fetal, and placenta factors interact in a very complicated way to cause the multifactorial etiology of SGA. Maternal nutrition, maternal diseases such as hypertension, diabetes mellitus, intrahepatic cholestasis, etc., contributes to the growth of the fetals. Fetal factors such as chromosome abnormalities and genetic, epigenetic variations, as well as structural abnormalities, determine the growth potential of the baby. Placenta and umbilical cord abnormalities disrupt the appropriate quantity of nutrition and oxygen supply to the fetals, such as abruption placenta, single umbilical artery, and thin or twisted or knotted umbilical cord. Other factors, including intrauterine infection, environment, tetrodotogens, or drug use or abuse, can also affect the fetal growth. SGA is now recognized as a fetal origin disease, which significantly influences the long-term health of the offspring throughout life. Today, I'll introduce the long-term consequences of SGA in short stature, central nerve system consequences, metabolic and cardiovascular consequences, reproductive health, and kidney issues. The introduction was based on the public literature review as well as data from our own team. Firstly, let's talk about the short stature in SGA children. As observed in clinical practice, catch-up growth occurs in most of the SGA children. It is characterized by a growth rate greater than 0 SDS and is critical for SGA children to reach a normal height range. Catch-up growth is most pronounced in the first 6 months of life and typically concluded within the first 2 years. However, for preterm and SGA infants, this catch-up growth may extend up to 4 years of age. Studies suggest that SGA children who are below 2 standard deviation in height at 3 years faces a 7-fold risk of remaining short in adults, where those with birth weight below 2 standard deviation have a 5-fold increase risk of remaining short stature. The reason for inadequate catch-up growth in children born SGA are not clear. Recently, we published a review article to discuss the possible mechanism. Researchers have proposed 2 main models to explain catch-up growth. The first is the neuroendocrine hypothesis. The second is the growth plate hypothesis. This can be seen as pathophysiology in short SGA children. On one hand, short SGA children exhibit lower spontaneous growth hormone secretion, lower HF1 level, or IGF-1 resistance in non-catch-up SGA children compared to those with caught up in growth. On the other hand, SGA children with inadequate catch-up growth exhibit abnormal skeletal development, including short bone length and lower bone mass compared to AGA infants, with catch-up growth in height falling to fully restored bone mineralization. This suggested regulatory issues at the growth plate and the growth hormone insulin-like growth factor axis regulation levels, causes of catch-up failure. Moreover, there are multiple factors, including maternal, perinatal, and offspring-related factors can influence catch-up growth in SGA children. Perinatal factors mainly include prematurity and infection. Maternal factors seem to play a significant role, which encompass height, smoking, pre-pregnancy weight, gestational weight gain, gestational hypertension, prematurity, gestational diabetes, overweight, obesity, constipation, anxiety, and parity. Well, the fetal neonatal factors include genetic facts, infection, nutrition, appetite, and thyroid-stimulating hormones. The detailed molecular mechanisms could be related with dysfunction of signaling pathway critical for skeletal development, epigenetic regulation of IGF-1 pathway, or hypothalamic programming, and the alteration of gut microbiota profile. Overall, further investigation of the underlying mechanisms should be conducted to achieve the prediction and effective treatment of inadequate catch-up growth. Children faces a variety of neurodevelopmental disorders and neurobehavioral problems. The molecular mechanisms of neurological disorders are still unclear. Maternal factors, including nutrition, inflammation, and disease, perinatal injury, together with genetic predisposing factors, have a great impact of the developmental priming pathways, such as cytokine or inflammatory mediators, adaptive immune system complement pathways, blood-brain barrier integrity and permeability, and epigenetic changes. Together with the postnatal diseases modifying factors, including systemic infection, environment, stress, and aging, disturbs fetal brain maturation, which in turn disrupts neurogenesis, neuronal migration, and myelation, as well as formation of neural circuits and refinement of synaptic functions. This merits effects results in long-term impairments in brain function and behavior. There are a variety of neurodevelopmental disorders in SGA children, such as decreased perceptual performance, defects in short-term memory, and impaired motor function, cerebral palsy, cognitive delay, speech delay, and abnormal behavior, including attention deficit and hyperactivity, and ASD. Moreover, there are additional factors that could increase risk of neurodevelopmental disorders in SGA children, such as growth issues, including early growth delay, poor catch-up growth, slow head growth, prematurity, abnormal imaging findings, and perinatal events, including asphyxia, HIE, sepsis, meningitis, and NEC. Regarding the cognition problem in SGA children, there was a systemic review and meta-analysis just published in 2020 in JAMA Pediatrics. It included more than 50,000 children aged from 1 to 12 years old from 60 studies. The results showed that preterm children who were SGA were 1.56 times more likely than those with AGA to have borderline intellectual impairment, and 2.77 times more likely to have intellectual impairments. Term-born children who were SGA had significantly lower cognitive scores compared with those with AGA. This suggests that born SGA is significantly associated with lower childhood cognitive outcomes in preterms and term-born children compared with children with AGA. We conducted a systemic review and meta-analysis in aspects of mental disorders in SGA children. I'll show you some unpublished data from my own group. To analyze the impact of SGA on ASD, we analyzed 12 cohort studies. As shown in the figure, we found that children born SGA had a significant high risk of ASD with an odds ratio of 1.15 compared to those with born AGA. We further characterized the SGA into preterm, full-term, and unknown gestational age groups. Based on the gestation age, the odds ratio for ASD risk was 1.22 and 1.07 for preterm and full-term SGA respectively. Regarding ADHD, 3 studies including more than 20,000 SGA were examined. The estimated odds ratio for ADHD risk in SGA births was 1.6, indicating a significant association between SGA and ADHD. Both preterm and full-term subgroups showed significant increased risk of ADHD with the odds ratio of 1.84 and 1.55 respectively. Given the limited data on childhood depression of SGA births, our meta-analysis included studies on depression outcomes across a wide range of spectrum, from adolescence to adulthood. 8 studies covering 30,862 SGA and 120,000 control explore the relationship between SGA and depression risk. We found a significant association between SGA and childhood depression with an estimated odds ratio of 1.06. Subgroup analysis showed no significant association for depression risk in preterm SGA, while full-term SGA demonstrated significant link. Due to the scarcity of childhood data on anxiety outcome related to SGA births, our meta-analysis included studies spanning from adolescence to adulthood. 4 studies were included to explore the link between SGA and anxiety risk, involving 16,034 SGA and 300,366 control participants. There was a significant association between anxiety and SGA with an estimated odds ratio of 1.53. Furthermore, preterm SGA showed no significant association for depression risk, while full-term SGA demonstrated a significant link. Overall, these results showed children born SGA have significant increased risk of neurodevelopmental and neurobehavioral diseases, such as impaired motor functions, cerebral palsy, cognitive delay, ADHD, ASD, and anxiety. In most cases, preterm birth is a critical fact which could further increase the risk, except for anxiety. Children born SGA also have increased risk of metabolic diseases such as obesity and type 2 diabetes. Catch-up growth is associated with increased risk of metabolic disorders. In children born SGA, there is a gradual development of insulin resistance from birth onwards. Insulin resistance is already detected by the age of 1 to 4 years in those with spontaneous catch-up in weight. In addition, in children born SGA who remain short, no evidence that type 2 diabetes mellitus, impaired glucose tolerance, clinical relevant dyslipidemia, or hypertension occurs more commonly. Importantly, the risk for metabolic disorders can be amplified by the presence of some risk factors such as overweight, obesity, intensity, and family history. A study published in 2008 and enrolled 297 Caucasian girls from the central western part of Poland. The girls were 10 years of age at the start of the study, and measurement of body mass and height were repeatedly performed until the age of 16. 77% of the girls were born SGA, AGA, and 22.6% were born SGA. Catch-up growth had occurred in 65.7% of girls born SGA. Girls born SGA in whom catch-up growth was observed showed the highest volume of BMI at age of 8 and at the time of menarche. SGA girls without catch-up growth were characterized by the lowest BMI value in relation to the other analyzed group. The results suggest that catch-up growth in girls born SGA is associated with higher BMI value in prepubertal and pubertal period. The PAR theory may explain the association between catch-up growth and metabolic disorders. Poor nutritional environment in early life can induce structural and functional changes in key organs responsible for nutrients regulation, including brain, liver, adipose tissue, muscle, and pancreas. So-called predictive adaptive response, the PAR or the PAR concept. Exposure to adverse environment factors may program for long-term appetite regulation, feeding behavior, as well as adipose tissue and pancreatic beta cell dysfunction in the developing fetus. Such metabolic adaptation may provide short-term survival benefit in the poor postnatal environment, but may predispose the child to type 2 diabetes in a condition with a food abundance in postnatal life. The fetal insulin hypothesis could explain the long-term risk of metabolic diseases observed among individuals with a lower birth weight through both genetic mechanism and intrauterine programming. The placenta is critical for integration of environmental signal. This process is mediated in part by increased expression of IGF-1 and its receptor, suggesting a compensatory mechanism in response to fetal growth restriction, and could induce other changes to promote influx of amino acids and glucose from maternal blood supply via the placenta to the fetus. After birth, a period of increased insulin sensitivity occurs, which then gradually decreased related to postnatal weight gain, that is the catch-up growth. These changes could in turn be associated with adverse body composition and increased cardiovascular risk. Children born SGA have increased risk of cardiovascular diseases as well. SGA is often resulted from placenta insufficiency. Placenta insufficiency have two direct effects on fetal cardiovascular development. First, reduced oxygen and nutrition supply may disrupt cardiomyocyte growth and fiber architecture. Secondly, venous hyperplasia leads to increased placenta resistance and chronic cardiac afterload. Additionally, these effects could induce epigenetic changes. Consequently, all of these factors working together leads to a cardiac remodeling in fetus. In organ level, it can be found as changes in fiber orientation, abnormal coronary vascular tree, increased vascular intima media thickness. In tissue level, can exhibit reduced number of cardiomyocytes, higher cardiomyocyte mean volume, and diminished capillary length and number. In subcellular level, it is shown as shorter sarcomere length, mitochondrial rearrangements, and changes in tetherin and myosin isoforms. Studies also revealed a U-shaped curve relating to size of birth weight with long-term mobility, with both SGA and large for gestation age, or LGA, associated with increased risk of cardiometabolic diseases. 4 longitudinal studies that included large and homogeneous cohort of young SGA adults indicate a higher prevalence of cardiometabolic risk parameters. Subjects born SGA have parameters suggestive of a higher cardiometabolic risk in adulthood when they experience a rapid weight gain in early life. It indicated the association between being born SGA and the cardiometabolic risk in later life, especially in those with born SGA with accelerated weight gain in early life. Moreover, a study investigated the impact of SGA on cardiovascular disease. It included more than 3 million singleton births from Sweden and Denmark during a median follow-up period of 10 years from age 18 years onwards. 30,000 individuals developed incident of cardiovascular disease such as hypertension, ischemia heart disease, or cerebrovascular diseases. Compared with individual born with AGA, individual born severely SGA were at increased risk of cardiovascular disease. The association was attenuated when comparing individual born SGA with the AGA sibling. The results showed that SGA is associated with elevated risk of cardiovascular disease in early adulthood. Familiar confounding factors might also play a role in association between SGA birth and cardiovascular risk. Born small for gestational age had a continuous long-term impact on cardiometabolic health of offspring. In fetal stage or newborn period, cardiac and vascular changes like left atrial dilation, septal hypertrophy, and impaired function can persist to childhood as cardiac remodeling and vascular issues. Childhood and young adult showed continuous cardiac and vascular effects with some compensations. In maturity, SGA birth is linked to higher triglyceride, LDL, cholesterol, and blood pressure, though association may be influenced by body size. It highlights the importance of life cycle monitoring of cardiovascular disease problem in SGA population. Born SGA have a great possibility to affect the reproductive health in children. The mechanism that how SGA affect reproductive system were unclear. Adverse intrauterine environment such as malnutrition, hormonal fluctuations, and chemical exposure during gestation have been shown to influence the pubertal maturation and adult gonadotropic function. Changes in the hypothalamic KIS1 system, the GABAergic, glutamatergic, and GnRH neurons could be involved in these processes. Most children born SGA have a normal pubertal maturation. Puberty starts slightly earlier, but within the normal age range, depending on ethnicity. Age in menarche is on average 5 to 6 months earlier, and pubertal progression is on average but slightly fast. In contrast to girls born SGA without accelerated postnatal weight gain, earlier pubertal maturation was found in girls born SGA with accelerated postnatal weight gain, such as exaggerated adrenarche and premature puberty, slightly younger age, menarche, and higher incidence of polycystic ovarian syndrome. The study investigated the effect of SGA on menarche in girls. It is from the study, as mentioned earlier, in the metabolic consequences, the proline cohort. The median age in menarche for the target group was 12.85 years. The age in menarche differed significantly between the three groups, the SGA catch-up growth, SGA no catch-up growth, and AGA. The first menstrual bleeding occurs the earliest in girls with born SGA with catch-up growth, and the latest in SGA girls without catch-up growth. This indicated that catch-up growth in girls born SGA is associated with earlier appearance of menarche. The impact of SGA on gonadal function remains a subject of debate. Normal gonadal functions were found in several SGA cohorts. In contrast, some studies found no differences in serum inhibin B, testosterone, FSH, and LH between young SGA and AGA men, suggesting that being born SGA does not impair Sertoli and Leydig cell function. In young women born SGA, no differences were found in anti-Müllerian hormone levels compared with age-matched women born AGA. In a small study group of young women born SGA, elevated gonadotropin concentration associated with reduced size of uterus and ovaries. A reduced ovulation rate was found. Recently, we reviewed the studies on effect of SGA on male fertility, and the results was published in Andrology in this July. 5 studies were with more than 1 million participants who born SGA or AGA were evaluated. All results showed that SGA was associated with increased risk of male infertility with the odds ratio of 0.91. As we know, age is an important factor affecting reproductive and fertility outcomes. The participants were then divided into 2 age groups: early adulthood age from 18 to 35 and middle age from 35 to 45 years. We found that reproductive rate of both young and middle-aged men born SGA were lower than age-matched males born AGA. Kidney disease is another long-term consequence of SGA. Clinical data and experimental studies have identified a variety of factors that are associated with intrauterine growth restriction and preterm birth, and the mechanisms through which they might adversely affect kidney development. Ultimately, these factors leads to reduction in the number of functional nephrons formed in the kidneys of affected infants at the very beginning of life, which in turn increases the susceptibility to the late development of kidney disease. A study from Norway analyzed the effect of SGA on CKD, or chronic kidney disease. A total of more than 2 million individuals were included. After a mean follow-up of 26 years, it showed that SGA with the odds ratio of 1.79 for CKD. Fortunately, other studies shown that glomerular filtration rate, blood pressure, and urinary albumin to creatinine ratio at the age of 21 years is similar between young adults born SGA and those born AGA. At last, here are some take-home message I'd like to summarize. Children born SGA have increased risk of a variety of diseases, including short stature, neurodevelopmental disorders, metabolic diseases, cardiovascular diseases, reproductive health conditions, and chronic kidney disease. Catch-up growth occurs in 80 to 90% of children born SGA. The differences in growth patterns potentially related to its different long-term consequences. Long-term large-scale observational studies, as well as basic molecular studies, are still needed to uncover the impact of SGA on long-term health. Thanks for your attention.
Thank you, Dr. Luo, for this interesting topic. I believe that SGA is more than just height. We as endocrinologists normally just monitor height and get concerned if they don't catch up growth and then the use of growth hormone. But with your lecture, it's more than clear that it's a more complex issue being SGA. I have a small question for you. You know, there's a lot of, or you were saying on your talk that obesity, for example, is one of the main metabolic consequences of SGA, as well as cardiovascular diseases. There's a lot of research around the world related to probiotics and the so-called gut-brain pathway. Is there any role, or do you see any potential role for probiotics in this research of SGA?
Yeah, I think this is probiotic biota is a very important factor on SGA infants for the late life development, probably including the growth as well as obesity development, as well as the long-term development of metabolic several studies. We trying to identify specific spectrum of microbiota to which acting on different spectrum of aspects of the late aspects, including growth pattern as well as obesity. And we did some the fecal transplantation therapy, even trying some study on for some special diseases, including Prader-Willi syndrome, as well as growth retardation abroad. And those preliminary data actually showed some very interesting results, showing this microbiota might play a very important role in late life, basically, and growth, and also obesity and metabolic syndrome development.
Thank you. Thank you. There is a question here from Dr. Mohamed Abdullah, who had severe protein energy malnutrition in infancy, prone to develop similar problems later.
Beg your pardon?
So it says, are children who had severe protein energy malnutrition in infancy, are they prone to develop similar problems as SGA later in life?
Yeah, I think this is a very important issue for the protein and energy malnutrition is very important, because since most of our actually animal model actually were based on this mechanism, we're trying to during the fetus's development with of introducing growth retardation on the late life development is mainly on malnutrition and protein intake, and this is probably the basic mechanism for the late life, for the effects of introducing growth retardation. Yeah.
Okay. We have another question. It says, what are the known or studied differences between the SGH who catch up and those who don't catch up their growth? How to predict those who will catch up their growth and those who won't?
Well, as you know, most of the catch-up growths occurs at very early life, in a post life of 3 to 6 months, and usually they will concluded by the age of 2 years old, or for the preterms they were concluded by the 3 to even 4 years old. That depends on how do you how the pattern of catch-up growth is very important, especially for those catch-up in weight is more likely to have develop to insulin resistance, and late life they were developing into metabolic syndrome. Or for those with catch-up in NANS, in height were less likely to have a predisposing effect on the metabolic effects on even the cardiovascular events as well as metabolic syndrome. So we will try to maintain the catch-up growth. Try to avoid too much caloric or intake, and try to avoid weight and to prevent the late onset of metabolic syndrome.
Thank you. I have another question here. For the SGA that you follow in clinic, do you do extensive checkup for prevention for all the consequences that you mentioned? If not, do you think it will be necessary, useful to do so?
Sure. Theoretically, it would be nice to do, all the follow-up. That depends on the situation of different region or country, and or the economic status of different region. It would be nice to do all the follow-up. Actually, in China, we do have very good we call women's and children's healthcare system. We do regular follow-up on those children born small for gestational age. So in very early life, we're trying to, like I said, we're trying to provide enough or abundant nutrients and to help the SGA children to have catch-up growth, mainly in length. And well, sometimes you may not be able to do that. And for those children, they are failure to catch up at 2 or 3 years old, especially for term babies. We would like to, sometimes if the baby was, the children was less than 2 standard deviation, if the height was still less than 2 standard deviation, we will try to initiate growth hormone treatment under very strict monitoring. So that's actually applying of growth hormone would increase the height as well as change the body composition, and probably with the very good monitoring and good use of growth hormone, we could improve the body composition and also increase the height and to help the baby to realize the catch-up growth and to diminish the possibility of cardiovascular disease risk.
Okay. I have a question for you. In terms of growth hormone, when do you start? Americans, this part of the world, based in Costa Rica, America. So Americans tend to do 2 years. Europeans tend to do 4 years.
Right.
In your lecture, you mentioned that those who are very small for gestational age, less than minus 3 standard deviations, can take up to 4 years to do catch-up growth. From your clinical point of view, when is the best time to start growth hormone?
Yeah, as you mentioned, I could totally agree with you. Like for the consensus provided by different societies. In United States, decided for 2, and European decided 4. In China, we actually recommended to start with 3 to 4. It's in between of US and European. That depends actually on the real mechanism or the reason or etiology of those SGA children. But like I said, for the preterm baby, they will have a longer time to catch up, let's say, until 3 to 4 years of we were closely monitoring the growth pattern as well as checking the clinical manifestation to say if there is any possibility of other genetic or epigenetic reason to cause the small gestational age. Like for some special condition like Prader-Willi syndrome or Angelman syndrome or Silver-Russell syndrome, we might initiate growth hormone treatment as early as just right after we make a diagnosis after neonatal periods. So a recent study actually showed, including some clinical trials in China we've conducted. We're trying to, for the Prader-Willi syndrome, we actually started to treat those SGA caused by Prader-Willi syndrome patient. We started with age of 3 to 6 months. So that all depends on on the etiology of the disease, also on the economic condition, as well as parents' opinion as well. Yeah.
Okay, thank you. So far we have no more questions, and I think we're off time now. Thank you, Dr. Luo, for your interesting talk and for all your answers. And I hope everybody enjoyed this meeting. And I don't know if you have any closing statements.
No, thank you very much. This is our first GPED virtual symposium. I think it's very successful, and it's my pleasure to participate this event. And thank you.
Thank you. Thank you so much. Have a good night, because I see it's.
Thank you. It's a very late night. Yeah. Thank you. Yeah.
Good night.
Good night. Bye.
Thank you very much. This session is now over. The next session are oral presentations. Please move via the Feedloop platform to navigate to the next session, which is the oral presentations. Thank you.
This meeting is being recorded.
Good morning, good afternoon, good evening to all who are joining us from around the world. My name is Diane Stafford, and I am a pediatric endocrinologist at Stanford University in California, in the U.S. And I'm also very pleased to be one of the vice. All for these sessions have been enjoyable. and I want to welcome you to our oral presentation session. I want to start by thanking everyone that submitted abstracts for this meeting. We had a wonderful response to our call for abstracts with 46 abstracts submitted from all over the world, which was truly wonderful. After review, we have chosen 6 abstracts for oral presentation, which you will now hear. But I also want to point out that there are 33 posters that are posted under the Showcase tab on the left side of the
This meeting is being recorded.
Significant kyphoscoliosis at a later age. Therefore, it becomes very important to look for these fractures in the childhood and adolescent period so that we can deal with it and try to remodel these bones before they stop growing.
Right. Another question, in a 1 year of OI patient, no fractures and no densitometry can be performed. Any biphosphonate usage indicated in that patient?
Sorry, I missed the last part. So
asking
there's no
for the
bone fracture.
biphosphonate treatment in a case without any fractures of the clinical OI, without densitometry at the age of 1 year.
No need for treatment. Again, you need vertebral fracture history and bone mineral density. We don't tend to do it in 1 year. Our normative data is usually a bit
Other
later.
treatments for osteoporosis other than the biphosphonate. Any experience?
Good point. Good point. Don't go near denosumab. Don't do that because it causes significant hypercalcemia. Beyond that, there is nothing there which is available. The supportive one.
This meeting is being recorded.
About 12.2% of the whole cohort. What we found, this is a distribution of age group, the people aged between 30 to 39 from the Arab region is compared to rest of the global responses, and as you can see from the bar chart, there are slight differences. Work settings a bit. There are some difference in distribution as well. Most people in the Arab countries, they are equally distributed between either practicing in public services only or both public and private. Whereas from people the rest of the world, majority of them are practicing in public services only. From this graph, the follow-up approach, frequent checkups for patients live with type 1 diabetes as well as celiac disease was more common in Arab healthcare professionals compared to people from the rest of the world, as you can see here on this graph. And the percentage of standardized approach was less in people practicing in Arab countries compared to the people from the rest of the world. So it seems to be that people practicing in Arab countries, they are more frequently seeing their patients who live with celiac and type 1 diabetes mellitus. In terms of perceptions on challenges that met for those particular patients, the Arabs feel the glycemic control is more difficult to be controlled for these patients compared to other practices, and therefore the practitioners in Arab states, they feel those patients who live with celiac disease as well, type 1 diabetes, they need to be frequently seen, and therefore that's what we see here. More than 60% of responders from first group practitioners in Arab countries, compared to about 40% from other practitioners in rest of the countries. The rest of markers there was no much difference and no statistical differences in terms of the need to have multidisciplinary clinics. So it seems to be that it's similar between the two groups, as well as gluten-free diet reduces the hypoglycemic episodes, the same perception we had from both groups. And about the gluten-free diet, adherence is more challenging, about same responses. No need for further insulin doses increasing, same responses. Psychological support needed, same responses, and need for more guidelines. Basically, as you can see here, the majority from both groups, they feel there is a need for more specific guidelines for patients who live with diabetes, type 1 diabetes, as well as celiac disease. So the main findings led us to conclude that glycemic control difficulty and follow-up needs are perceived differently between the two groups. Physicians practicing in Arab countries would arrange more frequent follow-up appointments, and both groups had similar views in terms of the effectiveness of gluten-free diet in reducing hypoglycemia, adherence challenges, and the need for psychological support and detailed guidelines. Thank you very much.
Thank you, Dr. Al-Safar. I will ask you a couple of questions that I hope you can. One is probably a quick question, which is how did you define frequent checks versus routine checks? Was that well defined in the survey, or was that a perception for people?
It was a perception from people. Well, we know that the standards is for patients who live with type 1 diabetes mellitus, and I presume that is known to everyone, that needs to be seen at least 4 times a year as per the international recommendations. So when we ask the question that it needs to be seen more frequently, so we are directing that it's more than 4 times a year.
And my other question is, it's interesting that your colleagues in Saudi Arabia and Arab countries feel that glycemic control is more difficult. I'm wondering if you have a perception on why that is. I realize that realizing that that's not probably not part of the survey, is that feeling may be present.
My feeling, since I practiced in one of the Arab countries, I practiced previously in UK, for example. So for people in the West, they could get gluten-free diet on prescription, and they have different choices and options they could select from. Whereas in Arab countries, there's a big struggle for them to get access to gluten-free diet. So it's not easy for them to get access to that, the limited options, and therefore to be strict on gluten-free diet could be a challenge for them, therefore the glycemic control as a result of that.
Well, thank you very much. That was a really great presentation. Our next speaker is Dr. Mokhtar Ba, who will be speaking on the evaluation of the management of diabetic ketoacidosis in children and adolescents with type 1 diabetes at 2 hospitals in Mali.
Thank you.
Dr.
Yes,
Ba.
I will share my screen. You will see.
Yes, we can. You're good.
Okay.
Yep, you are all set.
So thank you. I would like to thank the organizing committee for giving me the opportunity to share with you the results of our study about evaluation of the management of diabetic ketoacidosis in children and adolescents with type 1 diabetes at 2 hospitals in Mali. I have no conflict of interest in relation to this presentation. To introduce, diabetic ketoacidosis is a life-threatening emergency of type 1 diabetes whose prevalence and incidence are increasing worldwide. And hypoglycemia, hypokalemia, and cerebral injury can occur during decay management, and this risk can be significantly reduced when pediatric treatment guidelines are followed. In Mali, decay in children and adolescents is managed by adult endocrinologists who are not familiar with specific guidelines for pediatrics. The objective of our study was to describe the management of decay in children and adolescents with type 1 diabetes in Mali. What methodology did we follow for this study? This was a 7-month prospective and descriptive study conducted in 2 hospitals in Mali, Sominodolo Hospital in Mopti and Mali Hospital in Bamako, where there is neither a pediatric endocrinologist nor a pediatric intensive care unit. In this study, we included all children and adolescents up to 18 years of age with decay defined as hyperglycemia greater than 200 milligrams per deciliter, serum bicarbonate less than 18 millimole per liter, and ketonuria at less 2 cross. And decay resolution was defined as by negative ketonuria. Here are the main results we obtained. And we include 24 patients with a mean age of 11.3 plus or minus 4.9 years, and the sex ratio was 0.5. The median glycemia was 385 milligrams per deciliter, and the median bicarbonate was 12 millimole per liter. The median anion gap was 18.6 millimole per liter, and the median glycated hemoglobin was 14.5%. The median amount of fluid received by children was 474.3 milliliter per square meter of body area per hour, and patients received a median amount of insulin of 0.3 international units per kilogram per hour. Insulin was given as an hourly intravenous 10 units bolus because a continuous infusion device was not available. And in addition, patients received an initial 10 units bolus given intramuscularly. Patients received a median amount of potassium of 1.9 millimole per kilogram, and hypoglycemia was the main complication occurring in 20.8% of patients. Unfortunately, we recorded 1 death due to cerebral injury in a newly diagnosed 9-year-old girl. In conclusion, the management of decay in children and adolescents in our setting is characterized by administration of higher than recommended amounts of fluid and insulin, high rates of hypoglycemia, and 1 death in a population of 24 youth. Therefore, an algorithm in line with recommendation and available local resources to prevent decay management related complication is urgently needed. Thank you for your very kind attention.
Thank you so much, Dr. Ba. I will start by asking the question that actually you answered at the end, which was that there was a protocol, that you need a protocol for pediatrics. Do they have a protocol for adult management, or is it a individual decision making?
Yes, we have a protocol for adult patients, and we manage children with the same protocol, but we sometimes can reduce amounts of insulin or food if the children is so young.
Yeah, I think my impression from your data is that the doses of insulin are very high, or higher than I would be used to seeing, and the amounts of fluid are also higher than I would be used to seeing in pediatrics. So I applaud you for getting the data and being able to and hopefully now being able to put together a protocol that would be more appropriate for children. I think that the next step would be to think about their protocol and your protocol, which sounds like a wonderful thing to progress with from this.
Yes,
So we are running a little bit late, so I'm going to thank Dr. Ba and move on to our next presenter, who is Dr. Maria Camila Schrader Florence, who is going to be speaking to us about a pediatric clinical case of probable, I won't get the name right, siderosterolomia, and I'll let her do that. It's early here. A challenging diagnosis for rare disease. My brain won't put myself around that at this early in the morning. So, Dr. I will let you take over.
Okay, I'm going to share my screen. Are you seeing my screen?
Yes, we are. It's perfect.
Okay. So hello everyone. My team and I come from Colombia, and we are so excited to be here. I'm going to present to you a pediatric clinical case of probable cytosterolemia, a challenging diagnosis for a rare disease. We declare no conflicts of interest. Cytosterolemia is an autosomal recessive disorder that results from mutations in ABCG5 or ABCG8 genes. It is characterized by increased absorption and decreased biliary elimination of plant esterals, leading to their accumulation in plasma and tissues. Markedly elevated plant esterol levels can predispose to the development of premature atherosclerosis and early coronary artery disease. Therefore, an early diagnosis and a prompt treatment are essential to prevent these complications and to improve prognosis. A low plant esterol diet is the primary treatment for cytosterolemia, which differs from most types of dyslipidemia, recommendations that actually exacerbate this condition, and we will show you why. Oh, sorry. Plant esterol, such as campesterol, cytosterol, and stigmasterol, are molecules predominantly found in plant-based foods, such as vegetables, fruits, cereals, and nuts. Dietary consumption of these molecules is generally considered beneficial, since these molecules competitively inhibit cholesterol absorption. However, in cytosterolemia, dietary intake of these molecules is contraindicated and actually can be deleterious. So this is why it is so important to identify this condition and to differentiate it from most types of dyslipidemias, because consumption of these esterols can exacerbate the condition. We present the case of a 6-year, 5-month-old male patient with a history of painless tendinous lesions in heels, and inflammatory erythematous papules on elbows and knees. Physical examination showed two symptoms on elbows and knees, as you can see in the photographs. Metabolic workup was performed, revealing severe hypercholesterolemia with otherwise normal results. Gas chromatography could not be performed due to economic restraints, so we were not able to measure plant estrol levels. Initially, the patient was prescribed atorvastatin and ezetimibe. Then a whole exome sequencing was performed, revealing two variants in the ABCG8 gene, a pathogenic variant and a likely pathogenic variant. The pathogenic variant corresponds to a nonsense mutation that leads to a truncated protein, while the likely pathogenic variant leads to substitution of leucine by proline in position 533. According to genetic database, the first variant found in the coding region of the ABCG8 gene at position 1083, where guanine is, let me show you. Here. At position 183, where guanine is replaced by adenine, as you can see, it's pathogenic. It received a 16th point in the American College of Medical Genetics and Genomics classification, or ACMG classification, with two supporting predictors, PVS1 or pathogenic very strong, and PP5 very strong or probably pathogenic, very strong. This is a heterozygous variant that has been already reported by other authors in literature. The second variant found in the same gene causes a nucleotide change at position 1598, where thymine is replaced by cytosine. And it received, this is a very rare missense mutation that received a 6 points in the ACMG classification, being classified as moderately pathogenic PM2 or probable pathogenic PP5 strong. These results, along with clinical suspicion, led to the diagnosis of probable cytosterolemia. The atorvastatin was discontinued and ezetimibe was continued in a dose of 10 milligrams per day, along with a low plant estrol diet guided by a nutritionist. Since the beginning of the treatment, we saw that there was a significant reduction in cholesterol levels, as you can see in this table, since the beginning of the treatment on March 2023 up to the last follow-up that was in January 2024, mainly in LDL cholesterol, which is known to be predominantly elevated in cytosterolemic patients. We also saw that there were almost complete resolution of symptoms, as you can see in the photographs on my left. So what can we say as a conclusion? We can say that cytosterolemia is a rare disease with wide phenotypic heterogeneity and an unknown prevalence due to underdiagnosis. We report the case of a pediatric patient with a probable diagnosis of cytosterolemia in a developing country with some diagnostic challenges that were overcome. In our results, one of the alleles was likely pathogenic, so we were not able to verify the diagnosis. Furthermore, advanced methods such as gas chromatography that could help us to differentiate cholesterol levels to plant estrol levels could not be performed, and genetic information from both parents was unavailable. Nevertheless, clinical suspicion along with genetic results made the diagnosis of cytosterolemia probable, and a proper treatment was begun, leading to the clinical and biochemical improvement that we have shown before. Actually, we perform an in vitro expression functional assay supporting the pathogenicity potential and molecular basis for the clinical findings mentioned before. Thank you.
Thank you very much for that very interesting presentation. We do have a couple of questions. One is, are there other patients that are followed by your group with this particular disorder? It's clearly very unusual, but you did a remarkably good job of diagnosing it, which makes me wonder, makes us wonder whether you've seen it before.
No, we actually don't, and there's like a very there's no more reported cases of cytosterolemia. There is like less than 100, I think, globally. It's a very rare disease, actually.
So you did a remarkably good job of picking it up and diagnosing it, which is great. So there's no evidence that there's a founder effect or of the mutation in Colombia, but do you know if that exists generally?
No.
It runs in particular groups? No. Okay. Question is the intervention for the family to follow.
It's very difficult because as we saw, we generally recommend that diet in almost all patients, or actually normal individuals, because vegetables, fruits, and all of that are considered beneficial. And as we saw, plant esterol actually decrease cholesterol levels or cholesterol absorption. So it is so difficult because in these patients, unlike other dyslipidemias, this can be actually deleterious for patients. So it was difficult, but as you can see, when the patient followed that strict diet, there was a significant reduction in cholesterol levels.
Yeah,
So
I mean, it sounds like it looks like it worked very well, but I can't, but it also strikes me that must be a very difficult diet to adhere to, and it looks like they have done a remarkably good job. So interesting presentation.
Thank you.
We will move to our next presenter, who is Dr. Ty Pasquini, who will be presenting on the genetic testing access and results for patients with congenital hyperinsulinism as conducted through the CHI and University of Exeter partnerships.
So congenital hyperinsulinism is the most frequent cause of severe persistent hypoglycemia in newborns and in children. Genetic testing can identify a disease-causing variant in about 40 to 50% of these cases, and this genetic diagnosis can guide medical and surgical decisions and can help have a better sense of the prognosis of what treatments will be most effective for the individual. So in 2018, Congenital Hyperinsulinism International, which is a global nonprofit focused on improving the lives of individuals living with HI, that focuses on support, research, and awareness, partnered with the University of Exeter to fund genetic testing that would otherwise be unavailable to individuals around the world. The testing starts with the KATP channel genes, and then, if necessary, goes to a broader scope of the other known genetic variants. And the rest of our presentation will be a little bit about some of those results. So to date, 932 individuals with HI from 63 countries across 5 continents have been tested through this program. An additional 682 samples have also been provided from family members. The highest referral rates are from India, Turkey, and Vietnam. But as you can see from the map, it really is a global participation. Of the individuals tested, about 53% were found to have a disease-causing mutation, which is right in line with what we would expect generally from what's in the literature. The mutations identified were across 19 different genes, with the most common being the KATP channel mutations, with ABCC8 being the most frequent and KCNJ11 being the next most frequent. And then here's a list of some of the other genes that were identified in this testing in less than 1% of patients. One of the really important pieces of using genetic testing to guide treatment decisions is in focal hyperinsulinism. So this is a situation where a gene is identified and is as a result of one paternal recessive mutation. In focal hyperinsulinism, a lesionectomy can be performed, which allows individuals to go on to be essentially cured and have no ongoing problems associated with their hyperinsulinism. So this was found within that ABCC8 and KCNJ11 inheritance pattern in about 34% of individuals, and obviously is a very important way to ensure for greater success in treatment. Within those inheritance patterns, 66% had the biallelic or dominantly acting mutation confirming diffuse pancreatectomy, which needs treatments, medical treatments, and more complex management, including sometimes feeding tubes and other treatments. So Chi and Exeter have enabled 490 individuals to receive an accurate genetic diagnosis. This has led to better patient care, especially in individuals who may not have been able to access genetic testing if it hadn't been for this program. This also allows for a more diverse group of patients to access this care, including the access to the information, the knowledge about the genetics of the disease, which is not only important for treatment, as I've mentioned, but also helps enable the parent and the child to make better decisions for family planning and for choices about their future in terms of what care they may need to seek and getting any additional connection into the HI community generally. We're hoping to use this information for future studies, and the body of the genetics that have been brought together are actively contributing in our ability to hopefully find some of the genes that have yet to be discovered in that 40 to 50% of people who have an unidentified gene responsible for their underlying HI. Thank you so much.
Thank you very much. Really, really interesting. So the first question, I think, is about how people gained access to the testing, how you had things set up so that you could actually facilitate getting the samples to test.
Yeah. So if a doctor has a patient that they believe has hyperinsulinism, then the doctor, there's information on our website, I can put it in chat, but information about getting the samples to Exeter. So there's a form that the doctors would fill out on behalf of the patient, and then the samples are either sent or coordinated to get to Exeter, sort of depending on what the options are for where it is, but that can sometimes be logistically challenging, which we help support as much as we can.
The next question is is there further support once the genetic diagnosis has been made in terms of investigation according to mutation, suggestions about treatment, possibilities for pancreatectomy? Is that part of the sort of outreach of this?
So there's follow-up information that's provided to the doctors, and we always invite individuals to become part of the greater network, to join the mailing list, and to tap into the other resources that are provided not only by the Congenital Hyperinsulinism International, the worldwide nonprofit, but also, if necessary, if surgery is going to be necessary, there are ways to then sort of tap into the channel of the networks of the other experts who may be able to provide additional information. We recently published an international starting point for how to manage care site and provided to doctors in the follow-up with the genetic testing report.
Great. I think that's so important that people, not just that they have the diagnosis, but that they learn what resources are available for treatment in the longer term. I would invite you, please, if you're willing, to put the link to CHI and any information that people might want in the chat, in the feed loop chat, where it will stay for, where people can actually have access to it. Because I think learning about these things and then also figuring out how we can in settings where otherwise it would not be possible is really critically important. So
great, thank you so much. I'll add those there.
Yes, that will be lovely, and that way we can send that along to people. So thank you so much. That was really very, very interesting. interesting information. Our next speaker, we're coming back to Dr. Hussein Al-Safar again, who will be speaking to us on an adolescent living with uncontrolled type 1 diabetes mellitus develops acute coronary syndrome, the first case reported from Oman in a pediatric population. So Dr. Al-Safar.
Thank you very much, Prof, again, for this chance to present again. So let me take you through this interesting case. I have no conflict of interest and the background of this case. But before we dive in, let me just tell you as a background here that the acute coronary syndrome with silent infarcts is a common and dreaded complications of type 2 diabetes mellitus in adults. However, its incidence in long-standing fully controlled type 1 diabetes mellitus in children is relatively unknown. Patients with DKA typically presents with symptoms of vomiting, abdominal pain, which are often managed with antiemetics like ondansetron or its analogs. Let me take you through our patient KA, who is 13 years old, diagnosed with type 1 diabetes mellitus about 3 years before her presentation. She is on MDI regimen and she's poorly adherent to the management plan. As you can see here that the HbA1c managed to drop since diagnosis, but then flipped again to very high HbA1c, reflecting on poor adherence and management. And then she managed to actually drop it down again. But since January 2024, things were not in the right direction. As you can see here, HbA1c is more than 10%, which is relatively high. Her AGP, the ambulatory glucose profile, 2 weeks before her presence to emergency department, as you can see here, the average glucose was 17.9 millimole per liter, and the 50% of readings above the target. As you can see, most of the readings were above what is expected to be. And you can see here, just 2 weeks before presenting, the number of the percentage of data is much less than what it used to be. So 36% of available data, loss of interruption. That indicates that this patient stopped checking glucose frequently. Therefore, we have some data erased from the download. So she's not just not adherent to taking the insulin perhaps or do carb counting, but she stopped checking her glucose as she used to be. So she presented on that day to emergency department with abdominal pain, and she found to have just mild DKA. On examination, she was alert, conscious, not in distress, but she looked lethargic and having nausea. Normal vital signs and systemic examination was unremarkable. So she was started on IV fluids following the DKA protocol. Because of the nausea and vomiting, IV granistrone 2 milligram was given, and the granistrone is similar to ondansetron. It seems to be one of these analogs, serotonin receptor selective antagonist. Soon after, she developed central chest pain that was radiating to the left side, and she felt lightheaded. That was associated with facial pallor, cold extremities. The heart rate was 124 beats per minute, and she was crying with that because she felt weird, with blood pressure of 96/54 millimeter mercury. The first ECG here does not show ST elevation to go with the symptoms. If anything abnormal in this ECG, perhaps a little bit of ST depression on the chest leads. But that doesn't reflect acute changes. So she had another ECG, and now we're doing what we call it the posterior ECG, basically, trying to look if there's any changes in the posterior lead. So this is so-called as well the 15 lead rather than the 12 lead ECG. You could perhaps hardly seeing anything apart from very mild ST elevation, if you see here in V1, V2, just very mild elevation. But there is a trick from the cardiology colleagues, which is doing the mirror image of the ECG. As you can see here, this is a mirror image. And here you could see, and the posterior lead, clearly you can see the ST elevation. So that goes with posterior STEMI, ST elevation myocardial infarction. And she had further investigations. You could see here that at the time when she had the chest pain, not long after, within an hour, she had troponin, which is normally below 14 nanogram per mil. It was found very high, 359, so that you cannot ignore such elevated troponin in a young child. So she had urgent echocardiogram, as you can see here. With that ECG changes, if I put the cursor here in the middle, so with the movement, if I put it here in the middle, if we have a problem with the posterior wall, so if we say like there's a posterior myocardial infarction, so we should see that the posterior wall is not moving, but we could see it moving here from two aspects or two views, indicating there is no proper myocardial infarction because all the walls of the myocardium is moving. So that doesn't go with the posterior STEMI. Therefore, we looked into other causes. Does she have a congenital anomaly in her heart? So urgent CT cardiac cardiogram was arranged to look into the structure of the heart, and she was booked further for cardiac MRI to look into the all the coronary arteries and the shape and anatomy of the heart. And she was started on conservative management by adding aspirin, clopidogrel, and heparin, just to protective mechanisms. And she was put in observation, obviously, in the high dependency unit. As you can see here, the troponin starts coming down slowly. No abnormality was detected on the cardiac MRI. And then we concluded that she might have just transient spasm in the coronary arteries. We concluded from there that patients with uncontrolled type 1 diabetes mellitus, they need to have diligent follow-up and precise adjustment of medications. It remains challenging managing diabetes among adolescents. Although acute coronary syndrome is rare in pediatric population, the severity of potential complications necessitate a heightened vigilance for acute coronary syndrome in similar cases. And this case raised awareness of possible side effects of serotonin receptor antagonist and reinforces the need for further research to clarify the interactions between type 1 diabetes mellitus, DKA, and cardiovascular events. And of course, early detection and appropriate management of ACS are essential for better prognosis and reducing both morbidity and mortality. And thank you very much.
Thank you very much for a very interesting case, certainly highly unusual. We have one question, which is, in your practice, do you recommend cardiovascular preventative checkups for adolescents who have very poor control? Essentially, is there a way that her poor control might have predicted the need for an evaluation before she presented acutely?
So we don't normally screen for cardiovascular disease, apart from checking the blood pressure in each visit when patients come to see us in the clinic. But there's no particular investigation that we do for the heart, for retinopathy, nephropathy, neuropathy, but we don't normally examine the heart like doing ECGs or echoes, as we are not predicting or expecting such diseases in such young age. We defer and let our adult colleagues to look into this, but we do monitor for blood pressure, certainly each clinic visit.
And your point about the difficulty of control for adolescents certainly is interesting. I thought one of the interesting things about her presentation was that she had such mild DKA. She clearly had been taking enough insulin to not get into trouble, but with a significantly higher A1C, and it was certainly a good catch not to think of her as just being somebody in DKA, but actually having a related but difficult problem. and, and catching that she actually had such a significant issue to start with. Would this change your practice at all, having had this experience?
Well, I'm more vigilant nowadays of given the Down syndrome or Granny syndrome. I wasn't aware of this rare side effect of it. Looking into the literature, actually, there are some case reports about patients in different age groups who responded in that way in terms of having chest pain following acute coronary syndrome for patients who receive the serotonin antagonist. So yes, that's going to change my practice to be more vigilant for this and more aware of this side effect. And perhaps we are more aware of, as pediatric endocrinologists, we don't manage acute coronary syndrome that much in pediatrics. But now, yeah, we know how to manage it and what to monitor for.
Right. Yes. Well, thank you for the presentation of a very, very interesting case. Certainly highly unusual.
Appreciate it.
So thank you very much, Dr. Al-Safar. So we will turn to our last presenter in this oral session, Dr. Gloria Ikomba, who will be speaking about growth, vitamin D, and calcium profiles in diabetic ketoacidosis in Kinshasa, a clinical study. Dr. Ikomba. We cannot hear you, Dr. Ikomba. I'm not sure what is going on. It doesn't look like you're muted, so maybe it is the audio on your end. Oh no. See if your microphone, look at the audio settings, or if there's another microphone you can choose.
Is it okay?
That is much better. Beautiful. Yep, now I can hear you. Beautiful. Can you hear us is the question.
Okay.
Great.
Is it okay now?
It is. You may start whenever you like. And your screen is shared, so you should be ready to go.
Okay. Next, please. Okay. Thank you for the floor given to me, and many thanks to GPED for the opportunity to share the results of our study entitled Growth, Vitamin D, and Calcium Profile in Diabetic Adolescents in Kinshasa. It is a clinical study. Next. We know that adolescence is characterized by a rapid growth and development, and several factors participate to this phenomenon, including diet, hormone, and existence of chronic or metabolic pathologies. In case of malnutrition, growth retardation, vitamin D, and calcium deficiency are reported, same to the T1D, and so in the T1D adolescents in context of malnutrition, the situation could be aggravated. The objective of our study were to compare growth, vitamin D, and calcium profile of TD1 adolescents versus a control group, and to assess the probable role of the TD1 in this profile. Next. It was a prospective cross-section descriptive study on 60 adolescents aged between 13 and 17 year old during 6 months in Kinshasa in Democratic Republic of Congo. The variable of study was body mass index, Turner score, vitamin D, and calcium. The logistic regression was used for association study, and the p-value was significant if inferior to 0.05. And we note that the parathyroid hormone growth factor and calcitonin was not available in our environment. Next. About our main result, we note that the sex ratio male on female was 0.57 and middle age was 14. About the nutrition, 21%, either 70%, were malnourished, on which 69.9% severely in the T1 group versus the 43.33% in control, and the p-value was 0.003. About the growth, we noted that the growth standard was found in 66.66 versus 33.33 in control, and p-value was 0.001. About the calcium profile, we note that the calcium deficiency was found in please, next slide, please. Okay. About the calcium profile, we noted that the deficiency was found in 83.33%, of which 36 was severely found in T1D group versus 33.33% in control, and the p-value was 0.003. About the vitamin D, we noted that the deficiency was found in 90%, of which 36% was severely deficient in the TD1 group versus the 20 in control group, and the p-value was 0.002002. So we noted that the association between T1D, growth retardation, vitamin D, and calcium deficiency was significant. Next. In conclusion, our study shows that the TD1 adolescents had growth, stunted, vitamin D, and calcium deficiency. And we saw again that there is a limited access to endocrinological exploration in Kinshasa, and this is a challenge for the research and the care. So we think that there is an emergency and the necessity for the international collaboration for pediatric endocrinology in sub-Saharan Africa and particularly in Kinshasa. Thank you for your attention.
Thank you so much, Dr. Kombo. That's a very interesting study. Do you think that one of the questions that's come up is that changing how vigilant you might be in terms of asking about or trying to counsel about dietary intake or of dairy or other things that may help to prevent some of the vitamin D and calcium deficiency in patients with type 1 diabetes? Oh, you could not hear me. Can you hear me? It's hard? Okay. All right. This is whether this changes the way you would think about prevention of these of the issues, particularly around vitamin D and calcium, by counseling for more dietary calcium intake, more dairy intake to try to improve the situation.
Okay, we think that there is first a problem of a nutrition, a approach of nutrition, because in the country, in our environment, the diet is not equilibrated, and so we think that the first of all is the problem of nutrition, because the men children is the problem. Have the problem of nutrition is the global context. We think that if we can give a supplementation, it can participate to resolve the problem. But we think again that because of the diabetes and insulin action and the pathology, the diabetes, equilibration of the diabetes can be also one way to for the prevention of this phenomenon.
Great. I think, so thank you for that very interesting presentation. I hope that you can find some solutions to the issues that you have raised with this research, for sure. With that, I'm going to thank all of our speakers for their presentations today and for taking the time both to submit their abstracts and to be with us for these presentations, and close this session. We have one more session today. I would encourage everyone to go back to the main Feedloop platform and join that session. So thank you very much to all our speakers and for everyone for being here today.
Thank you.
Thank you.
Thank you.
This meeting is being recorded.
Good morning, good day, good evening. This day we're gonna have the last session of the day with a beautiful plenary session by Catherine Chaussin. So the role or the feature of teeth. Catherine Chaussin is a professor of dentistry, of odontology, and she is also a researcher and a great professor in her university, Paris Cité in Paris, France. So Catherine has been involved for quite some years now in research, especially in research affecting bone in children, and when it affects the bone, it very often affects the teeth as well. So she highlighted the importance of the tooth features in pediatric disorders and how we can use this to make diagnosis of diseases in children. So in addition to research work, Catherine Chaussin is also a clinician, a physician, and she sees patients with disorders affecting the bone, and she's a very good, very important contributor to our multidisciplinary clinics for these patients. So I will not stay longer and because we need to hear what she has to say. As this is a plenary, we may not have time for a question at the end, but you are very welcome to ask them on the chat, and we will try to respond even later. And so, Catherine, the floor is yours.
Good evening, everybody. I'm Catherine Chaussin. I'm a dentist, academic dentist at Université Paris Cité, where I run a lab working on tooth pathophysiology and biomineralization, and a dentist working in a reference center at the Assistance Publique Hôpitaux de Paris, dedicated to rare disorder related to phosphorus and calcium metabolism. This reference center is related to the French filière Oscar and to the Iran bond network. I have no conflict of interest to declare except a research collaboration with Kayora Kirin and research consultant with Novo Nordisk. Most of the endocrine disorder also affect the tooth structure or its morphology. And you see that you can have many kind of manifestation, either related to the form of the tooth, to fusion of the teeth, or to the structure with abnormality of the mineralization process. All these alterations deeply affect the patient's quality of life, and we have conducted a study in patients with X-linked hypophosphatemia and show that oral manifestation deeply alter the quality of life of this patient, whatever was his or her age. Tooth development is an extremely complex process. It results from a dialogue between the dental epithelia that invaginate within the mesenchyme, the dental mesenchyme that derive from the neural crest. And this invagination results in a unique crosstalk between the epithelia and the mesenchyme, giving rise to the dental germ, which goes through several stages: bud, cap, bell, and at some stage there is a degradation of the basement membrane between the epithelial and the mesenchymal compartments, with a direct dialogue between the dentin secreting cells odontoblast and the ameloblast secreting cell ameloblast. And this results in the formation of a tooth with a very hard structure, the enamel, and the core of the tooth, which is the dentin, and is the major mineralized tissue in the tooth. The tooth is anchored in the periodontium through a very specialized mineralized tissue called the cementum, which is also very similar to bone. The important thing to know with the tooth is that the deciduous teeth form during the prenatal period mainly, and a couple of months after birth. So it means that all the pathologies or events that are going to affect this prenatal and perinatal period will have impact on deciduous tooth mineralization. permanent teeth, and especially the first molar, start forming at birth. And this is all through growth. And it's quite periodical and quite with event well defined. And whatever event or treatment or pathologies that will happen during afterbirth, during this period, will be present into tooth mineralization. What is interesting to know is the structure of the dentin, the main tissue of teeth, is very similar to bone. It's mainly an organic matrix made of fibrillar collagen, essentially called type 1 collagen, phosphorylated protein and non-phosphorylated protein. But the difference between bone and dentin is that bone is doing modeling and remodeling, but dentin is modeling, is formed, but never remodeled, which means that whatever is going to be the event that occurred during this formation is going to be registered within its structure. All the dental tissue can be associated with several disorders. In blue, you have the conditions that affect only enamel or only dental. This is isolated form of amelogenesis imperfecta and isolated form of dentinogenesis imperfecta. In my country, these conditions are explored by gene panel for amelogenesis imperfecta or for dentinogenesis imperfecta. And you have also trouble of abnormalities of enamel, dentin, and cementum that can be associated with syndrome. And this syndrome can be either related to the extracellular matrix, and this is very often the case for associated to constitutional bone disease, such as osteogenesis imperfecta, osteopetrosis, and you have some impact on dentin and or cementum, or to the mineral metabolism, such as hypocalcemia, hypercalcemia, hypophosphatemia, or hyperphosphatemia. And you can have manifestation on dentin, cementum, and enamel. In general, what is related to calcium and to the kidney has more impact on enamel, and what is related to phosphate metabolism and to bone is more related to dentin and cementum. So the main objective of my presentation will be to show you that it is possible to discover new links between teeth and a rare endocrine disorder. To have a dental examination will improve the dental phenotype. You will understand the pathophysiology of a rare endocrine disease by studying mouse model or human teeth. And it is what we do in my lab, really to try to get some insight from the mouse dental phenotype or the human teeth directly, as you can have access to dental teeth because, of course, children lose their primary teeth and they are very important organs to study biomineralization. Teeth allows to assess the impact of new treatments, and I will show you, for example, the treatment of XLH. And it is important for this patient, as I've been telling before, that all this manifestation deeply affects the quality of life to develop adapted and specific dental care. I will start by the endocrine disorders related to the mineral homeostasis. And the first part is the phosphate axis. And this phosphate axis, when it is disturbed by a rare endocrine disorder, has mainly impact on the dentin, which is very similar to bone, and on the cementum, which allow the anchoring of the tooth in the jawbone. Of course, you also have, as for the rest of the skeleton, a problem on the alveolar bone. I will start by talking about hypophosphatemia, which is really important for tooth mineralization, and of the most prevalent form of hypophosphatemia with high FGF23, which is X-linked hypophosphatemic rickets, which is due to FEX pathogenic variants. In these patients, you have several clinical manifestations, including leg bowing, short stature, osteomalacia, and joint pain in adult, endopathies and bone fissures, skeleton deformity, regrets, craniosynostosis, and severe dental manifestations, which are related to odontomalacia. This is a major dental manifestation associated to XLH. It is what we call spontaneous dental necrosis with severe abscess on deciduous or permanentis that look perfectly normal. And this is not usual. You see here, this first primary molar is associated with this big abscess, and the tooth looks perfectly normal with no clinical abnormalities, no decay, no sign of trauma. And if we look at the X-ray, you see that there is no specific sign of pathology on this tooth. And still, there is a big abscess on this tooth that comes from a tooth infection that doesn't show manifestation on the tooth per itself. So this is very unusual. And when a dental practitioner or general practitioner receives a patient with this kind of abscess, he or her does not understand what is the origin of this abscess. It can be even worse, and more seldomly, you can have some maxillofacial cellulitis, which are extremely severe and often require an hospitalization of the children for a week to have some IV antibiotics. So what are the reasons of this infection? First of all, when you make some X-ray, you see that the dentine is very poorly mineralized. We have a hypomineralization of the dentine and very large pulp chambers, either in deciduous tooth or in permanent tooth, with pulp arms extending up to the dentino-enamel junction. When we make examination of this teeth with scanning electron microscopy, you see that these prominent arms are really coming to the tip of the tooth, explaining the human mouth is full of bacteria. And so you can imagine with the saliva full of bacteria, the bacteria directly have a highway to the pulp chamber, which is enlarged and cause this spontaneous necrosis. And you really see this opening direct highway from the mouth to the pulp chamber. If we go and look at the core of the dentine, you see here you have some control dentine, which mineralization looks very good. And in XLH teeth, you see that you have a hypomineralization of the dentine with what we call unmerged calcospheroids, which are really very easy to go through from the mouth to the pulp chamber to cause this necrosis. And what is very interesting, you see that really the dentine is affected, but you have a layer here between the enamel and the dentine, which is not altered, and is called the mantle dentine. So we can figure out that the mineralization process of this part of dentine is quite different from the rest of the core, which is poorly mineralized. If we make some ADX to see what is the mineralization process, you see that in this calcospheroid is the mineralization foci. You have some biomineralization. You see here the peak of phosphate and here the peak of calcium. And if we do EDX in these interglobular spaces here, which are not mineralized, you see that you have absolutely no mineral disposition. And here you have the pulp chamber, and we really can understand that bacteria go directly through the oral cavity to this pulp to cause necrosis. In my lab, we have been working extensively of what is the content of these unmineralized interglobular spaces, and we have identified, having bone or in the blood of patients with XLH, accumulation of degraded peptides of the extracellular matrix, and in particular, ASARM peptide, very acidic and mineralization inhibitor, ASARM peptide, derived from the sibling protein. Anyway, these parts are really strong inhibitors of biomineralization process and are typical of XLH. When I was a young dentist, I had the opportunity to see 50 patients with XLH. That was in the beginning of the new century. And all the patients are dots in white patients that were under treatment, and in dark patients who were not treated with the conventional treatment, meaning a phosphorus drop and vitamin D hydroxylated form during growth, and in white patients who were treated during growth. The black square represent the national French data regarding the oral health. This is the DMFT for Decade Missing Field Tooth Index, and each number represents a tooth. Patients with a very good oral health have a DMFT around 0, and patients with a very poor oral health have all their teeth which are affected, and the highest score is 28. So what you see on this schema is that most of the patients who were not treated during growth because the treatment at that time did not exist show very, very severe dental health. And I have to admit that most of them came to my chair and were removing their partial prosthesis. In contrast, patients who were under treatment, most of them are in white, show a much improved dental phenotype, which was consistent with the national value at that time in France. So what we were showing in this study is that vitamin D, hydroxylated vitamin D supplement plus phosphorus drops were improving the oral health of the patients with XLH. And the earlier you started the treatment, the better the oral health was improved. We made also some histology on teeth we were able to collect from treated patients. And this is the primary molar of a patient who was treated very early, a couple of months after birth. And you see that, remember what I said earlier, that dentin form but is never remodeled. And what you see is that the first layer, which was formed before the onset of treatment, shows this abnormal calculus ferrite. But after the onset of treatment, you see that you have a very correct biomineralization process of the dentin. Similarly, in this permanent third molar, this is a teenager who had these teeth removed because of orthodontic treatment. And you see that the treatment was, after the initiation of the treatment, the mineralization process was correct, and both of these teeth, either primary or permanent, were not infected. Of course, now there is most of the pediatric patient can be treated instead of the standard treatment with phosphorus drop and hydroxylated form of vitamin D by burosumab. And the first clinical trials were not very encouraging, showing more abscess in children who were under burosumab rather than patients who were under conventional treatment. But it was a short time. And I had the opportunity to follow 2 patients of the phase 2 clinical trial before the phase 3. And I've been following up these 2 patients, French patients, for 5 years. I will show you the female patient. There was a male and a female patient. And what I've been monitoring for 5 years is the biomineralization process of the first permanent molar. And what you see is that these children, of course, in the phase 2 clinical trial, were selected because they were showing very severe clinical manifestation, and both of them had numerous abscess on deciduous teeth. So I've been monitoring the biomineralization process under burosumab treatment of the first permanent molar, and you can see here that the biomineralization process is very correct for this young female patient for 5 years. And I show you, here is a patient treated for the same time with the standard treatment, conventional treatment. And you see that the quality of the dentin is much poorer in this patient compared to this these patients are here. You can see the halo of demineralization that are not present in this patient treated by birozumab. So we recently published a study showing in 71 children either treated with conventional treatment and or with birozumab that the number of abscess per month were significantly lower in children treated with birozumab compared to children treated by conventional treatment. So, of course, biomineralization of the tooth takes time, but the better is the correction of hypophosphatemia, the better the biomineralization of the tooth is. I will show you, just before closing the chapter of phosphatemia, the consequences of hyperphosphatemia on tooth mineralization. And it's absolutely the opposite of hypophosphatemia. So mutation, loss of function of FGF23 or GAL-TN3 give this calcinosis, hyperphosphatemia, familial tumoral syndrome. And you see you have this very abnormal mass of bone, of mineralization that are developing on unexpected location. It's ectopic mineralization. It can occur on the shoulder, on the ankle, on the hip, and this is on the elbow. And this bone mass are severely impairing the quality of life of the patient. On the dental standpoint, I had the opportunity to see 4 patients with this condition, either due to FGF23 or GALTN3. And what you see is that you have a complete biomineralization of the pulp chamber in this patient, which is exactly the opposite of what we saw in patients with hypophosphatemia. And you see that all the teeth are fully mineralized. It's very clear in this patient, but you have some ectopic mineralization also in the gum. And whenever you have a tooth decay, for example, in this patient, it's very difficult to treat properly the tooth because you still have infection despite the fact that the pulp chamber is very narrow. So to finish, I will talk to genetic disorder related to calcium homeostasis and to the kidney and the parathyroid. And most of these disorders alter enamel biomineralization. So enamel is the most mineralized structure of the organism. Upon tooth eruption, it is devoid of cells, so there is no possibility of regeneration, on the contrary to dentin. And enamel is a very precious tissue that needs to be repaired whenever it's lost. So you have conditions related to hypercalcemia or hypocalcemia, and I will show you some examples. Most of them are related to the calcium sensing receptor and its partner protein. So in my clinic, we have been seeing patients with gain of function of the calcium sensing receptor or of neurons. And what you see that is this patient with hypocalcemia show hypomature, hypomineralized amelogenesis imperfecta. And of course, there is a higher susceptibility. You see that most of the teeth are altered. And when you make X-ray, you see that these patients are enduring a lot of carious lesions, opening quite early, either in deciduous or in permanent teeth. And what is important is that this patient doesn't show the usual caries risk factors, such as poor diet, poor oral hygiene, and lack of fluoride in the toothpaste. And the surprising thing is that we also saw patients with loss of function mutation in neurons or CISR, so patients with hypercalcemia and hypocalciuria, FHH. And you see that you have quite a similar phenotype with hypomineralized enamel. And when you see this 16-year-old male patient, you have a lot of carious lesion in a patient that doesn't show caries risk, very good oral hygiene, and no sugar frequent uptake. And you see that you have exactly the same carious susceptibility that the patient with hypocalcemia. So this calcium sensing receptor is very axis is very important to study for tooth mineralization. We also made the characterization of patients with IPPSD2 mutation of oral maternal origin, and in this patient with pseudo-hypoparathyroidism, you have tooth malposition, of course, that will require an orthodontic patient, but you see that also most of them show hypomineralized enamel with this manifestation on the structure of enamel, and they will be more susceptible to caries due to this hypomineralization. I will show you also, I think it's important, patients with APSL syndrome, which are due to variants in pathogenic variants in the R gene, and you see that these patients also show hypomineralized enamel. In my lab, we have been working with a collaboration with Dr. Karine Guillonneau from Nantes, and we explore the dental phenotype of rats bearing deletion of the R gene, and you see that you have no obvious manifestation modification of the enamel volume or density on the continuously growing incisor and molars. However, we had access to deciduous teeth of patients with APSL syndrome, and we saw that globally the enamel structure was correct, which is consistent with what we found in rat, but we found some hypomineralized spots, such as this one. You can see the enamel prism, which are disorganized on this scanning electron microscopy picture. And recently, there was a publication showing that patients with APSL syndrome were having autoimmune form of amelogenesis imperfecta. And you see that they made a thorough examination of the enamel of the mouse model knockout for the R gene, and you see you find exactly the same disorganization of the prism at some location compared to wild type, similar to what we found in PET. Anyway, in this APSL patient, you have to be very careful of oral pain infection because the patient cannot manage with a dental pain, and it is very important for this patient to install a good dental follow-up. And to finish, I will show you some example of patients with growth hormone deficiency. And you see in this patient, you can have some modification of the eruption process of the tooth. You can have some delay or some, depending on the condition. And you can also have some abnormality of the morphology of the teeth or some fusion of the incisors, such as in this patient for the upper incisor for this patient, or here for this patient of the lower incisor. I will say a last word about Turner syndrome and abnormal enamel. This is a female patient, you see, showing a quite severe hypomineralized amelogenesis imperfecta, and you will have to schedule care for this patient. So the dental phenotype should be considered in the context of a rare endocrine disorder. The study of tooth mineralization may reveal new mechanisms of period or stress in the dentin or in enamel. The study of dental mineralization can help monitor the impact of the general treatment, as we show for the treatment of XLH and for, in particular, for the conventional treatment, but also for burosumab. I hope that my talk has shown you that the dentist will be involved in the medical team in charge of the patient, and all the patients with a rare endocrine disorder require specific and regular dental follow-up with adapted care to prevent infection, early tooth loss, and repair aesthetic and functional damage. And I will show you, for example, a clinical case of amelogenesis imperfecta. And you see that we have been following up this patient during all the period of growth with temporary restoration, and at the adult age, we can finally put some final crown with a specific zirconia to restore the aesthetic and the function for this patient, which is very important for the quality of life of the patients. So thank you for your attention. I'm happy to participate to this first virtual meeting online. I would like to thank people from my lab, and in particular, Dr. Claire Bardet, and from my clinical department, and in particular, Professor Martin Bios-Duplan, who is doing some periodontology in our reference center, Professor Elvire Lenorcy, and Céline Gaucher, who is doing the genetics of amelogenesis imperfecta and the dentinogenesis imperfecta. Also the medical colleague from the National Reference Center, and a special thanks to Professor Agnès Linglar and to the Oscar Network. And thanks to all our collaboration who are providing samples and murine model to study all these dental manifestations. Many thanks for your attention, and I will be happy to answer your questions.
Thank you very much, Catherine, for highlighting the importance of looking at and investigating the dental phenotype in patients with, as you said, any endocrine disorder during growth. So unfortunately, we don't have time for questions. This was the last session of the day. And so I thank you all very much. I thank also Catherine for a great presentation today at this plenary session. And I wish you a good day and a good evening.
Thank you everyone for attending the meeting today. So we're gonna see you tomorrow